All right, it is 5 o'clock, so let's call this meeting to order. This is the Kittitas County Public Hospital District Number 1, the regular board meeting for April 23rd, 2026. I just want to make a quick comment. The commissioner Erica is running late. She's at the school district, finishing up some stuff and she'll be here as soon as she can. I've not heard from Bob, so I'm not sure, but we have a quorum here, so we can continue. For the agenda, are there any comments about the agenda?
I'd like to make a request to add to the agenda, just under presentations, if we could add Dr. Larson, I'll give an update from the health department for a measles update.
We'll add him first under A and we'll move department spotlight to B.
And then just wanted to request to add under old business, just some discussion around with the master site work going on. If we want to continue to have what was our financial sustainability committee, our financial strength committee, just hand holding some of that work, then come back to the rest of the board.
Good. And then I want to declare 9B board bylaws will be a discussion tonight. We will not vote on that tonight. Any other requests for changes or additions?
Bob will not be able to make it tonight.
Bob will not. So Bob will not be here tonight. Thank you. So hearing none, I will entertain a motion to approve the amended agenda when ready.
I move to approve the agenda as amended.
Thank you. And I second it. Harry, any further discussion? All in favor, say aye.
Aye.
Aye. I too will vote aye. Anyone opposed? That motion passes. If you've had a chance to review the consent agenda, I will entertain a motion when ready.
I move to approve the consent agenda.
Thank you, Terry.
Second.
Second by Matt. Any further discussion? All in favor, say aye.
Aye.
I too aye. Say aye, sir.
Aye, yeah.
Thank you. Anyone opposed? That motion passes. So we are on to presentations. Dr. Larson, welcome.
Thank you. Mark Larson, Health Officer, Public Health. So the reason Erica's not here is because I've been having her work hard today on our measles outbreak that's happening in conjunction to Valley View Elementary School. So as most of you know, I've been the health officer here for 19 years. Before 2026, we've had 0 measles cases in Kittitas County. As of last night, we have 7 cases of measles in Kittitas County. We had our one case that was the young woman, college student, had no secondary cases for that. Her case was transplanted from South Carolina. She'd gone home to visit. So we kind of know where that one came from. Our second case was earlier this month, a young unvaccinated mom. She doesn't know where she was exposed, but she, as most of you that have been in healthcare know, there's people who are really good historians and people who are really bad historians. She would get the gold star for being a really good historian. She could say where she'd been. She kept her kids home. Her kids, of course, got measles from her. So now we're sitting at 4. We called those 2 kids epidemiological linked. We didn't go ahead and test them. We knew exactly where they got it from. They're all better. They've recovered. They're back to doing their thing. No second cases from that. Then we got another case who falls on the other end of the spectrum as far as historian. It took us a long time even to get some kind of a story that we could wrap together. We talked to lots of family members and she doesn't know where she got it either. Neither one of these 2 young moms had any travel outside of Kittitas County, no interaction with anybody with measles that they knew of. Unfortunately, her 2 kids that went to Valley View on Monday and Tuesday of this week started getting a fever and a rash and tested positive for measles. Unfortunately, unlike the first case, we couldn't really say, here's kind of what happened. I'm not still convinced that these 2 kids got their measles from mom. There was travel to a wrestling tournament in Spokane that occurred on the 4th of April. That would still be in the window of possible infectivity. So we talked to Troy Torno, who I know came and talked to you the last time I was here, and said, here's what we have going on at Valley View. We have 23 kids at Valley View that are non-vaccinated for a variety of reasons. I've talked to a couple of the patients' moms, one because they chose not to be vaccinated, another one because she couldn't get vaccinated. But those people that can't get vaccinated are the people that we're trying to protect, plus the people that are under 1 year of age, which if you've got a kindergartner at Valley View, you might have a kid that's under 1 year of age. So we went ahead and said all these kids have to stay home. Erica's, I'd be surprised she's here because all the rest of my health department people are still at the health department, which is where I'm going back to. The biggest problem, which doesn't affect the hospital quite as much because of the work that Mandy and her group have been doing in regards to figuring out how all of us fit in the measles immunization standpoint. So we know who here has had measles vaccine, who hasn't, who's had measles like me. Out of the almost 100 staff that we have at Valley View, I know zero of those people's immunization status. So I think what you'll see in the newspaper tomorrow is that they can't open school because they have no teachers, because from our standpoint at public health, they can't go back to work until they can show us their vaccination status. I talked to Jason earlier today, and I know Jason talked to Stacy. We have some
patients.
2 of them, I delivered their kids who called family medicine trying to get their immunization status, and because they hadn't been in the clinic for a long period of time, they weren't able to get their vaccine records. They may not even be at the family medicine as far as that goes, but I think we solved that problem. But we're going to see this over and over. You know, I think what we're seeing is community transmission of measles, which means the person next to you in Safeway could easily have measles and you're not going to know it. So it's going to be really important for us to work with businesses in town, with the schools. And of course, I'd like everybody to be vaccinated for measles, but even more important than that, and maybe something more attainable for me, is to have people know what their vaccination status is so they don't have to miss work. Because this could be, I mean, they canceled their
Oh, sure.
what were they having tonight? They were having a
Don't you?
talent show. Yeah, they canceled their talent show tonight. There was a lot of general angst about that. But I think what we're going to see is for sure tomorrow they're not going to have enough staff to open. And then that has really downstream consequences. Parents have to stay home, similar to what we saw during COVID. People have to stay home. They can't earn money because they're not going to work. And kids could fall behind in school. So it was a very hard decision to go ahead and take these kids out of school and kind of take this step. But it was really because I can't really tell where these kids got measles from. So we're going to see a lot more. I mean, and we're working on a state level on a couple of different things. So they're working with Dr. Merrill Steskel and the Washington Academy of Family Medicine to try to make sure that we in the clinic setting are updating our vaccines at every clinic visit. We've done that before. They said, oh, just contact the hospitals and look in the EHRs and you'll get people's vaccine status. I said, that does not work. Thank you very much for all the work you've done today. That does not work. And we're really worried about what's going to happen when we have the big soccer tournament coming. So never thought I would say the West Siders versus the East Siders, but I guess now I'm an East Sider. But the big counties on the West Side, they want to do things their way, and it's kind of putting us smaller counties at a disadvantage. So we're pushing back pretty hard on that on a state public health level. But it's kind of hard to push against King County. So that's what I have. Questions? Yes,
If someone is vaccinated, is it 100% effective?
97%. So out of those 1,000 cases in South Carolina recently, they had about 3%, which is consistent with what we see. If people have one vaccine, we're letting them go to work, but because it's down in the lower 90% effectiveness, but we'll be following them from public health standpoint. And as Erica can tell you from a school district standpoint, it's a ton of work. It's a ton of work for us at public health. Our one case of measles with the college student cost us $57,000. We don't have that money in our budget, but that's what it cost us. And it's mostly employee time to do things like checking on people's vaccinations and those type of things. Yeah.
Does it matter how long ago you got the vaccine, and does it wane as years and decades go by?
It'll wane, but like somebody like me who was born in 1956 and had measles, it's assumed that I still have a decent immunity from that. I was talking to somebody else who got a titer. So we've talked about titers in regards to the people that work at Valley View, but the problem is that if you get exposed today and you have a titer and you have immunity from your measles, mumps, rubella vaccine, we know that's valid. But if somebody is a week out from their possible exposure, you don't know whether their test is positive because now they have measles or their test is positive because they have immunity. So those teachers and staff at Valley View were really in the pool. Yeah.
Has the vaccine evolved at all over the last 50, 60 years? Is they given the same one today that they did back then?
It's very, very similar. Yeah.
That's fine.
Yeah, it's probably it's definitely the most effective vaccine that we have. And unfortunately, it's got some bad raps from a variety of, I had one teacher today who told me she was born in England, and that would have been about the time that Dr. Wakefield was publishing his study on measles, mumps, rubella vaccine, and its attachment to autism. And this particular teacher thinks that they didn't get vaccinated because that's the time that all that data was happening. So we're going to see more and more of that and make the school nurses, they are really the heroes in regards to this, and they don't get enough support, I think.
Are they able to access the state registry, checking that further?
Yeah, patients can do that themselves, and we do that. So we're calling every teacher at Valley View. So I'm going to try to make the staff leave by 10 o'clock. I don't know if I'm going to be successful with that or not, but because those teachers need to kind of figure out where they were, kind of like what we did at the college. A lot of those people say, well, my mom has records, or I got my immunizations in Iowa and my doctors died, or they saw Dr. Verney here and they don't have vaccine records there. And those are not going to be in the state vaccine database, just the ones that Dr. Merrill Steskel is giving us in the clinic. And just to talk about family medicine, when I was in at family medicine the last time, they looked at my immunization status and said, you're due for a tetanus. So I got a tetanus. I had no idea I was behind on my tetanus vaccine. So they're trying hard. It's just we need to get more people into family medicine and peds and internal medicine and do those things.
I think just two little ads. We did have a exposure in our ER, and we tracked, I think, did we have 10 employees that had exposure?
No, Anna's on it. She'd know the number off the top of her head. but-
Whatever it was, we had, say it was 10, it was 10 out of 10 that had all their records and their vaccines. So that was awesome to see. So kudos to our ER team to protect themselves.
It made a whole big difference in regards to the public health work for sure.
15 out of 15. So thank you and kudos to our ER staff and our staff for having those and having the record.
So,
And we've not got any secondary infections from that. We followed one person who got transferred from here and then came back and tested that patient again. earlier this week and she's still negative. So we didn't get any secondary transmission, even though by numbers, if you remember looking at numbers during COVID, we expect about 19 positive contacts for each person with measles. So it's very infectious, and just means even though I bugged the ER staff about wearing their masks appropriately and washing their hands and stuff, because I've learned from Anna that that's what I'm supposed to say. But they obviously did a good job because nobody got a secondary infection.
A smiley face. She gave us.
And Anna had just commented that 15 staff, is that at Valley View? Is that what?
No, 50 when we had the
Here, I see.
patient
It
come
was
to
in
the
Anna's
ER.
15.
Yeah.
Okay,
That we did
and all
not.
15 of them had verified record.
100%.
We didn't have to miss work.
That's
So
great.
you have to be, they would have, our employees, if they're exposed, not wearing their PPE and not vaccinated, would have to be excluded from work for 20 days,
21 days.
21 days. So it's really
then-
important that they are protected and wear their PPE. Because we've got to be here to care for the community too.
Right.
Or people
So are
have.
we
To teach, right?
Are we saying Valley View could be shut down for three weeks then?
It could even be more than that, possibly, just because if you get another,
Kind of starts.
if you get another kid, it starts the clock over again, or you get a teacher that, or some kind of a assistant, then it starts the clock all over again.
We're gonna be reaching out to all of our employees that we don't have records of having it and have some one-on-one conversations with. So we're going through our records to see, and then double looking at their mass fit testing as well. So we're going to be requiring them to have that done or not return to work.
I'll throw one more thing out about what's happening on public health level. And so King County the King County health officer, she's new. She's their new health officer administrator. She's from Georgia. She wrote a health order, which is kind of our biggest tool that we have at public health. It says you have to do this, that tells the jails in King County that their employees are mandated to have a measles, mumps, rubella vaccine. It has not gone through their union. There's going to be a lot of gnashing in teeth over that. But the whole reason is that if you have measles in the jail and you lose all your people that are doing that work, what are we going to do with those people, right? So that's what we're going to see probably for the rest of our lifetime, I would guess. So we're trying to see, we sequenced the mom, the first case that we had, and then we've sequenced the second mom and her two kids. They're probably all the same strain of measles, but it might help us some to decide kind of where this is coming from. But right now it seems like it's coming from here.
Two other questions.
Yeah.
Once again, a history question. At what point did the community in our community with as a nation start kind of getting a little more lax on vaccination? Is there a point where we start becoming more lax?
There's always been people on the left side of the political spectrum that were not wild about vaccination. So there's always that group. And then during COVID, when I was just talking to somebody who's the neighbor of our previous governor, and our previous governor said the hardest thing he did during COVID was mandating vaccine for Washington state employees. So we started mandating vaccine for the jail. We did that, and so people on the other side of the spectrum, political spectrum, said we don't really like being told what to do, and so it kind of started with that. Now those people are all meeting in the middle, and they have very similar views on vaccination. It's probably about 20 years ago. My wife works at the college at Student Health, and there's a lot of young college-age women that were not vaccinated by their parents. And it's not just measles that's the problem, it's rubella. That's the other big issue with that. So they've really been pushing those now young adults to review again the whole idea of whether they should be vaccinated or not.
Second one, what group of population doesn't qualify for the vaccine? Like what's the general reason of not qualification?
Medically qualifying would be like,
That's what
mom I talked to today, her daughter had chronic kidney disease, so her nephrologist said she shouldn't get vaccinated. I'm not sure whether that's a real true reason or not, but that was the one that the mom had. If somebody has autoimmune diseases sometimes or on certain medications, they can't get live vaccines. But it's not very many. And most of the people that have, and you've probably seen the exemption forms, but most of them are religious exemptions, the ones that come through, even though when I looked at that and when I talked to a lot of the faith-based organizations here in the county during COVID, and I did not find one pastor that said our religion says you can't get vaccinated, but we do have pockets of unvaccinated people in the county, and I would guess that our first case and our second case, those two moms somehow know each other, or those kids know each other, or somehow. I just find it hard to believe that they're not connected somehow.
So we're gonna get a couple of sandwich boards at our access points just for informational purposes, and then also just encourage people to check their records through the patient portal, through the Washington registry, and try to keep them out of our facilities. We have plans for how we can do testing outside. We've had these plans in place since 2 months ago when we had the first case. So it's worked well so far to test and keep people out of the facilities. When it does happen though, we do have to close those rooms like rapid access over the weekend. We had to close rapid access for 2 hours to let all the ventilation clear and then to have somebody come in and clean the area.
Is the test virtually instant or how does it?
No,
No, 72 hours.
Oh.
But the-
We're getting it back from the state. If it would go out tomorrow morning, we'd probably have it back in about 36 hours. We can usually get them to, I mean, they know we have a problem here, so they're kind of running ours first. But all those tests have to go through, because if every doctor that wanted to test for measles asked for the test, then they wouldn't have any space. So those calls have to come to us. And most of us have not seen measles, right? Even, I mean, we just haven't. So there's a big learning curve for providers as well.
We have a script or some sort of a protocol for when families call in and there is a concern about measles so that they don't come through the main waiting area or.
yes.
Okay, good.
Yeah, and we work with KVH about talking points and those things, and we always tell people to call before they come in. I mean, obviously, if somebody's coming in by ambulance, that's a different story, but we have pretty good ways of protecting the people that are here.
We sent out an all-employee message last week and we sent another one this ago as well.
And we made sure that, yeah, we've been coordinating with the health department the whole time to make sure what instructions the health department are giving are matching with the capabilities of healthcare organizations and then what we're sharing with patients and what we've built as, we've some decision aids for staff, and the poster board he was talking about is to help so that they stop and have a number to call
Okay.
before they enter the building. So been a lot of coordination.
Hard to unring that bell once it's
Yeah.
once the exposure is happening. Yeah. Okay.
So if we don't have another case at Valley View, those students can go back on the 6th of May, and the staff who probably most of them just can't find their vaccination records, they can go back on the 6th of May. So that's kind of where we're at with that. We'll keep our fingers crossed.
Any other questions for Dr. Larson?
Thank you for the 3+ minutes.
Yes, thank you for your time
Thank you,
tonight.
Dr. Larson.
Appreciate you.
All right, so moving on, we have Department Spotlight Dietary. Who would like to introduce that?
I can introduce Colin and Dr. Carden here, and then I know Alex as well, so they're all in there. Sorry, I can't, is it Garrett? Okay, and Garrett in the middle there, so they're here to present on podiatry. Take it away. Colin.
Welcome.
And you can tell everybody's positions, what they do. I'm sure you can go through that.
So KVH podiatry and orthopedics. So our providers, Dr. Carden and Dr. Johnson. Staff, Anna, our PSR, Garrett, our referrals coordinator, Alex, our lead PSR, and then myself. Our clinical team, so Annette, MA, Courtney, one of our MAs, and then Sydney Jones, our imaging tech. And just to look at our room there, our nice rooms, and our brand new imaging equipment that's on site over there. And so responsibilities of each role, patient service representatives and referral coordinator, PSRs are the face of the clinic, greeting patients, scheduling appointments, and Garrett is processing referrals, medical assistants, rooming patients, documenting vitals, assisting in procedures, and coordinating surgery scheduling, all Garrett. X-ray tech provides on-site real-time imaging services, giving providers vital diagnostic information that guides the treatment plan real-time in clinic. Providers, direct patient care and plan of care, the head of medical decision-making in the clinic. And some of the services we offer, and we are over at a former Suite D, now Suite 5130. And so I won't list everything off to you, but see it all there. And so our accomplishments, so open fully staffed on schedule 1/12/26 with roughly 45 days of lead time. So far, year to date, 866 patients seen. Clinic PSR staff taking out hospital imaging registration to allow our X-ray tech to take on increased patient volumes.
Is that unique patients or is that total visits?
Those are total visits year to date. So we are quite busy over there. Increased Dr. Carton's surgery volumes, Q1 2025, 9 OR cases versus Q1 26 with 32 cases. High patient volumes averaging 35 patients per day, coupled with reduction in patient wait time in the lobby from 22 minutes at opening in January to 12 minutes in April. So that's great with increased volumes and also decreased wait times. Don't always see those things correlating. Efficient and effective use of clinic space, sharing Suite 5130, formerly Suite D, located in the surgical services complex with KVH orthopedics, utilizing on-site radiology to improve patient care. That's a huge advantage to having podiatry join ortho in that space.
What are the most common surgeries?
Most common
Surgeries.
I would, Cardinal, defer to you.
It's a mix. I mean, I've got, there's the elective stuff that we're doing, say bunions, hammer toes, flat foot reconstruction, Achilles tendon, things, heel spurs, things of that nature. And then we have, our diabetic population where we're, incision and drainage, amputations, unfortunately, from time to time, things of that nature too. I'm picking up some of the trauma stuff from Dr. Longo that he's like, I don't want to do that. So I am doing ankle fractures and, anything in the foot that gets broken. If it needs to get fixed, we'll put it back together.
Okay.
So it's kind of blend.
Okay.
Different things.
You and Dr. Longo have teamed up on OR cases before, I believe.
We've done a few things together. Yeah.
Right.
Okay.
Thank you.
Can you
bet.
Back up one screen.
Sure.
So you were fully staffed 12/20/26. But in the middle, you've got a Q1 2025. So explain what really is happening here. Clearly, you had to be open before 2026 if you
So-
have records of 2025.
So Dr. Carden had practicing rights in our OR, but was still directly with Cascade Foot and Ankle without a direct association with KVH and leasing space on our campus. So that's just reflective of the new partnership we have.
Excellent. Thank you.
Yeah, I'd probably add, it's probably 2 years ago since I first met with Dr. Carden, maybe 3 years ago, and we talked about the practice that they're doing and asked what bottlenecks you had. And the biggest one, I remember you said, was prior authorization, referral coordination to keep things here local. So being a private practice and trying to do prior auths, it's not what insurances don't make it easy anymore. So that's been something that we've really, I think, improved through this relationship of being all under one, are that a lot better and we're able to support them a lot better.
And so we have some challenges and opportunities or availability. We're working with surgical services to expand available OR days. In the near future, we're looking at point of care ultrasound, voice activated. So that will be in a couple different areas, but that discussion is still kind of ongoing. Custom diabetic shoes and in-clinic laser treatments. So look out for a laser for capital later on this year.
A voice activated ultrasound.
So it's pretty slick, without going too nitty gritty. Dr. Carden is currently using a butterfly, point of care ultrasound. So that's a great tool in clinic. After trialing butterfly and Clarius, I believe the consensus is with Clarius. It's wireless and has voice activation. So just more hands-free time, what he's doing and less manipulating equipment. So
So a question before you go on. OR availability, what's the friction point?
Dr. Carden is very popular and we're still sharing him with Cascade Foot. So we have more of a lineup for OR dates than we would like, but we're working on getting that number down. And I'll hand it over to Dr. Carden.
Yes, so I've actually, I mean, I know a lot of you here, and I've actually practiced in Ellensburg for 30 years. So, Cascade Foot and Ankle is a practice that I've been part of. And like we talked about, we've had this discussion about coming on with KVH. And there's definitely been some things that have become easier with being in or under the umbrella, if you will. I do have three partners in Yakima that I work with, and there's some obligations there that I'm still need to take care of. But I'm glad to be up here. Great team. Getting to know everyone here, and like I said, it didn't take long for us to really get rolling, right? In regards to getting our volumes up and seeing patients. I like to be efficient. I understand, that from private practice. There's a way of, again, seeing people, getting the care that needs to be done in the right way. But at the same time, again, having people feel like they have the chance to come in and share their concerns, and then again, provide the care that needs to be provided. So Dr. Johnson and I have worked together for how long has it been? 17. So my wife came with me to that. We're gonna go to dinner after this. So I think Josh and I have worked together for 17 plus years. And so we know each other quite well. And he's a great physician also. He's covering more of our Yakima side. He's up here half day a week right now, and then I'm up here for the other. So, some of these things that we've talked about trying to get done here, there's just certain community services that still aren't available, like the diabetic shoe side of things. We used to just send them over to Kittitas Orthotics and Prosthetics. There's a lot of red tape that you have to jump through to get things like that done, and they don't want to jump through the red tape, which I totally get. So I can send for custom braces and other things, but they just don't want to do that. And we've done it for years, kind of understand the process. It's just a great way of us reducing risk factors for loss of limb. And so, anytime I can keep a leg attached, it's good versus having to take body parts off. So I think it's an important thing that we can add to the community. So right now what's happening is I'm either sending them to our office in Yakima or working that route. And again, I want to do it right. So we just want to make sure we get that one figured out. Ultrasound, I've been using it for years for diagnostics as well as for needle guided injections and things of that nature. And when we brought it up, I think then the other physicians under the KVH umbrella were like, well, there's lots of places this could get used. And so hopefully it expands into other areas and other folks are able to use the tool for what it's really meant to do. And so I think deciding on where it went and how it gets done system-wide is what we're kind of trying to figure out, so, but. Any questions for me?
Is it fair to say that demand is still up? You know, we have more potential customers than we can.
We're filling the schedule
Yeah.
pretty good with a full day in clinic with 35 patients. We're, 35 to 40 patients. We get a few add-ons in there.
How far booked out are you?
We are
Surgery wise.
surgery wise, we're out until July currently, which is a lot further than we'd like to.
I think I talked to
The
Annette.
28th of July.
Yeah, I talked to Annette
28th, we're
yesterday.
about to creep into August.
He's trying to open up 2 other days before that. We'll see if we can't make some things happen. So we're looking at it, trying to be creative. We had a little bit of a backlog in the transition. And so that's been part of this. I think we'll kind of get caught up and get to a place where we shouldn't have too much of that waiting going on, but acute stuff we're gonna get in and get done, obviously, when it needs to get done, so.
Can you speak a little bit, you might have covered this at the beginning, but how patients route to you in the first place? Are they being referred in? Are they self-referring or a mixture?
I think
It's
Most
a
are-
mixture, most of it's out of primary care. So an issue's identified, we get the referral from primary, or the referral comes to orthopedics. After case review, it's determined it'd be better with podiatry. There are some self-referral cases.
We do have urgent care and rapid access, both. People are out doing sports or activities, something happens and they get sent to us. So it's kind of a mixture. They call, we collect whatever information, or they're sent by some other provider.
I had my private practice that we're trying to reroute back into this also. So that's been a little bit hiccupy, but I think we're slowly getting that taken care of also. In regards to where they can go and how that happens, so.
Yeah, they're technically a specialty, so some insurances will require a referral from primary care, but some insurance, depending on the plan, can self-referral, so that drives some of that too. We did have podiatry up in Cleveland 2 days a month, but as you know, we haven't been doing that since one of Dr. Curtin's partners resigned a few months ago, but we do look forward to getting that service in Upper County as well, but it'll be some months until we restart those conversations.
We had some dialogue on it, so.
Yeah.
See what we can do.
But in the meantime, we're bringing all those patients have been able to be absorbed by Dr. Carden down here, or Dr. Johnson.
I think again, it's a challenge, right, to the central Washington. Right, when I came here 30 years ago, there were 3 podiatrists that worked in Yakima. We covered Ellensburg and Sunnyside. And here we are 30 years later, we have 4. Right, so there's not been a huge expansion.
I thought you only had 3.
There are, but there's Lashemina works for Astria.
Oh,
So there's one other guy that, that's our extra.
Got it.
And, part of it's been recruiting, part of it's been, just, changes that have gone on over time. So we still spread ourselves out from Sunnyside to Ellensburg, for coverage. So. Anything else?
Any other questions? Thank you for coming in today. It's wonderful to hear about what you're doing over there.
Yeah, glad to be here.
And so thank you. And we never like people to stay for the rest of the meeting.
It's okay. I'm gonna take my wife to do it.
Thank you. Thank you. All right, so we are moving on to public comment and announcements.
Before we proceed to public comment, I just wanted to give an update. Dr. Larson ran his way out and wanted me to update that Valley View is actually closed for tomorrow.
It is.
Yeah, they will be closed, probably working out some staff.
Okay. Very good. All right, so public comment announcements. Does anyone here like to make a public comment or announcement?
Being with staff, we anticipate we'll have a lot of call outs, so.
Okay. Well, if you're gonna make a public comment, I got something I gotta say first, about a 3-minute limit. Is there anyone online who would like to make an announcement or a public comment? Okay, hearing none, we will move on to reports and dashboards. With quality first, Mandy.
So, my report starts on page 13. And, before I take any questions, there's one thing I want to talk about. On Monday, Department of Health inspector arrived to, review our home health program for, our compliance with conditions of participation for CMS. So it's a DOH surveyor, but they're looking at CMS's.
And is this a surprise visit when they
Yep,
show up?
it's always unannounced.
Yeah.
So she came on Monday and spent a lot of time gathering materials. So Director Jackie Morris and Michelle Sexton worked on gathering those materials. It was her first day as the clinical supervisor. Maya Brissy had an exposure to this process and gathering things, but things like policies, whether it's our emergency preparedness policy or their policies about how they care for patients. So pulled all that together. On Tuesday, she went on visits with patients along with one of our home health aides. She said, especially Ducky, she really loves going on home health visits with her hospice visits. She had surveyed us before on our hospice survey. And then on Wednesday, we met and did some more record review with her and exited. And so there are likely about 5 findings related mostly to documentation. So how we document visits or the elements of visits, making sure you're using the right form so it captures the visits or the timing of it. So we will get the final report of the statement of deficiencies in 10 calendar days. And then we have 10 business days. They have more time. They have 10 business days to get us the report, and we have 10 calendar days to provide our plan of correction to them. So we'll be working on that. And
From what you know so far about any reason we can't fulfill that 10-day requirement with it?
oh, no, not at all. They're already working on some things, and it's a really great survey process. This is a great surveyor that comes. She provides a lot of feedback in the moment. So no, I don't doubt that we'll be able to have a plan of correction. And I think there are things we want to do and provided us what surveys should, where we're seeing maybe something we hadn't noticed because, it's the work we're doing every day, and having another set of eyes come in and say, hey, this is how this looks. So it's even things like for documenting when a patient has to miss a home health aide visit. What are we documenting as far as our communication with the patient and the provider about missing that visit?
Any
I think we can do.
surveys are very collaborative.
Mhm.
They bring you best practices. They sometimes take your best practice. So that's what you're seeing is this, we will correct the issues and follow up. And anyway, it was a good learning experience. So.
It's the fear that it's just like that.
Yeah, because it isn't always.
Yeah.
Yeah. And then, I'll take any question. Anyone has anything about my report?
Anything else you'd like to highlight on it before we take questions?
Not that I can think of right.
Any questions for Mandy's report?
I think I would just highlight the home health dashboard. If you look at this, they're all moving in a strong direction. So it's positive to see, and this survey will give us more opportunity to focus on some areas. We love that feedback from the surveys, and I just give a shout out to Jackie and her leadership in there over the last year. She came in and has been really doing a lot of work there to stabilize staff. I think she would almost overstaff their agency laser. She has one now,
I think just one.
and that one will become permanent as
Yep.
well. So she's done a lot of stabilizing, and the numbers are showing better as well.
She did a model job as a director. And so this was her first survey as a director, but she was open, transparent, responsive. She did a great job.
One of the things that we drilled down into in
Yeah.
the QI council was like the depression screening with the peds. It's not it looks so good, but that's not because they're not being screened, it's because they're being screened in a paper form, right? And the paper form isn't always being uploaded into the records. So we were talking about ways around that, ways to deal with that. But anyways, Mandy, you can speak to this more if you'd like, but you know, it doesn't look good on the charts, but that doesn't mean that the screenings aren't happening. It just means that they're not being registered. Do I have that right?
Yes, and that's a good thing to bring up actually, because the QI Council made a decision to go ahead and remove that from the dashboard. In the meantime, while we explore, yeah, so take the PEDS data line off the dashboard for now, while we go look at what's a more accurate way to measure that within the pediatric clinic, whether it's a sampling of charts and a manual abstraction, because it's happening. It's just the place where this data comes from doesn't get marked with their particular process. So we want to find a more reliable data method before we're putting it on the dashboard.
And we talked about the reason why they do it on the paper form is so you can just hand it and the kid can do it on their own, you know, that you're not having the parents sort of fill it out for them. So you get sort of an accurate measure, but getting it into the chart is not easy. And then there was a question of, well, maybe you could use tablets, but then that raised all sorts of other problems. Anyway, so they're working it out, but it's a higher number than it looks like just because of the recording. So is that right?
So just don't want to publish incomplete.
Right.
Data that doesn't reflect what's really happening.
That's right.
Okay. Sounds good and reasonable.
Now that you mentioned QI Council, though, I'm trying to remember if there were other things we wanted to highlight from. Not that I remember. Good, lots of good reporting there.
A lot of sick catch nominations this one too, so that was a really tough one to work through and actually choose just two.
Don't say them yet.
But that was, I'm not, I
Okay.
don't remember what I did last week. No,
Oh,
I had
okay.
Specific on those.
Yeah, Jason and I
But it-
gave the blows of
Yeah.
one of the votes.
Yep.
But,
There was a
luckily
lot.
we were able to work it out.
And it's just really warming reading them all, but hard to decide on one as well.
Well, as we remind everybody, whenever we give these out, everybody who's nominated is recognized in one way or another. So,
Yes.
anyway,
All right. Anything else for Mandy? Anything from your side?
No.
Okay.
Thank you.
All right. Moving on, and since we adjust the agenda, it will be Chief Executive.
well, we have,
Wait.
Oh,
we want to talk about the compliance report and the
oh, you're absolutely right.
You almost got away with it.
I tried.
So close.
All right. So Suzette, and 2025 annual compliance report.
Yes, yeah. Thank you,
Please do.
Okay, excellent. First of all, I just want to address the 2025 work plan. You have it in your packet, at this page here. Page.
I think it's
Okay.
28, I believe.
Yeah. I just want to point out that we did have, all of the items were initiated on this work plan and monitors ongoing improvement for 2025. Also, and I promise I will try and make this as interesting as a compliance report. Compliance effectiveness assessment for 2025. That is on this page. Yep, on the top. So just briefly, implement quarterly audits that will involve staff access reviews to include family members and coworkers. I'll go into more detail, but we did address that successfully in 2025. So I would like to just go ahead and jump to a recap for 2025. Beyond that, get into a little more detail. We had new policies introduced, the immigration enforcement policy, the video surveillance footage policy, and the section 1557 policy. Also policy document updates. So these are already existing, but they needed some required updates or just updates in-house, and they were the compliance program. Because we had some new leadership, we needed to add to that document. Hospital and law enforcement guide to healthcare disclosure. has had immigration enforcement frequently asked questions added to the end of it, and then we had to go through and adapt that to KVH. Also, the notice of privacy practices, won't go into detail too much with that because it was regulatory changes, so that's been updated. Highlights, a number of privacy and compliance concerns reported in between 25 and 26. So I'm very excited about that. That is on. Go to our chart. Yeah. You can kind of see the improvement there. 24 was 54 total, 25 with 112, and we are keeping that pace for 26. I like to think it's because we had a culture shift at KVH, only because I've been working on that for the last 2 years. So I'm hoping that's like where it came from. Partly that, and probably because of all of the support here for compliance and for privacy from everybody in the hospital. Also, staff accessing their own medical records. That was part of our compliance assessment that we just looked at. And I do feel like we have increased awareness. We had transparency on the audit process there. I wanted to bring an example. HR created a really nice step-by-step guide about this big that sits on a person's desk and it says, you know, do I have a reason to be in this chart? Should I be in this chart? And it just kind of takes you down step by step and then tells you, hey, no, I need to get out of it. No, I need to be, this is work related. I didn't bring an example, Janine, but Janine was the pioneer on that. So thank you.
I think that was, I think I gotta give credit to Jen and Ashley, and I think those two were the ones. That
Oh,
put it
did
together.
they?
I just gave my full support.
Okay, all right. So I'll have to thank Jen and Ashley also. And then we do have weekly audits that came out of this process. So once a week now from Cerner, I get a report that tells me when a staff member has been in their own chart. And luckily, I've seen a decrease over that. We actually have weeks where that number is 0, I'm happy to say, so. Keep working on it.
Yeah, Susie's done a lot of work to message to staff to get in front of people, that temptation to open your own chart, open a family member chart, open the person next to you's chart, because they're not supposed to open their own chart. So there was a lot of chart access happening.
If somebody opens their own chart, can they actually make changes to it?
They shouldn't, but they
They
can.
shouldn't even open it.
Right, they shouldn't open
If they
it.
do open it, it is possible to make a change.
Absolutely.
Depending on what kind of access they have.
Some of the things we were,
I'm sorry, Jeff?
Depending on what kind of access they have to.
Okay.
some of the things we were seeing though is like, I would open my own chart and send a message to my PCP.
Uh-huh.
What we ask staff to do is you're exactly like a patient, and a patient would not in their chart, they would use the portal.
Yeah.
So those are the pieces of education we're working on with staff.
Yeah, that was, because it's easier, you're already working in the chart anyway. It's a little easier just to pull up my chart, send a message versus going out, logging on to your own patient portal. Yeah.
And anytime somebody accesses it, it's time stamped and we would know
Yep.
what computer, who.
Yep.
was
Every
on.
time they click, we get
Yeah.
a stamp, time
I'll
stamp
take
and
a
where they
We
click.
click.
So we can know how long they spent, if they're in family members
Each
chart, we
place.
can see how long they spent in each area.
Is there ever, trying to think if there would ever be a reason for someone to access their own chart, because I mean, they're probably never assigned as their own healthcare provider, no?
That's why. I
Unless
make
you're
it
in
very easy
Antarctica doing
on
your
it.
own surgery.
Yeah.
What's that?
Unless you're in Antarctica doing your own surgery.
Yeah, or in space, yeah.
Yeah.
Yeah, it's-
Yeah.
Those are
Been
great.
done. Hopefully not here.
You just need signage around it, says, just remember, we
Yeah.
can see you,
Yeah.
sort of thing.
Yeah, we were doing, maybe we're doing another announcement again. We did quite a few announcements, just general reminders last year.
Yeah.
It's probably about due to send another just general reminder out, especially when you have so many new staff every group coming in.
Yeah.
So,
And this isn't just like hospital policy, these like regulations.
Yeah.
I mean, this is,
I mean, it's.
The law.
yeah.
Federal,
Yeah.
There's on occasion where, like, give an example of maybe a nurse seeing or doctor seeing like a family member, and they could, if there's no other clinician to provide that care, they can like note it in the chart, right? We've had that happen as well.
We've had access as a good example.
We've had that happen. We've also had lab staff, special nice if family members come into the ER, they're drawing their blood, they're running their lab tests, they're in the patient's chart and it's a family member. And there's no one else who could do that testing.
But like Jason said, that would then just be noted.
Right.
Here's why it's doing this. Yeah.
And I feel like the comfort level has increased, so now I get a lot of calls on that. Staff will just self-report. I had to, it was work related and they'll document and just call.
Susie will do a review and that comes out good. It's really great to see that. Yeah, Susie's did a lot of work on this.
Yeah.
I learned from the time. Unlike the other thing.
So the next small project I'll jump down to is our ISO 9001 document control committee that we formed this year with the help of Mandy and Van Bowling. Wow, I don't even know where to start. We started that, what are we at, a year ago now? And this great robust system, Lucidoc, that had, I think the last count was 1,800 pages of help in it. It's just
The help materials, yeah.
overwhelming for, our everyday users. So we were trying to figure out a way to kind of standardize part of that system and to make some help materials a little more accessible and just easier to use, because it was really, it's technical term and it's just not cut out for us. So, Jeff, but not the rest of us. So we started that voyage. So we created a standard of, then Mandy, both Mandys. Yeah, Mandy was on this also. Kind of standardizing terms, how titles are put into Lucidoc, and just so we can get some consistency throughout the organization on that. And that also led to some job aids on how to put in the different types of documents. And I'll make it short so I can go really long on this, but this also grew into a governance committee that we had our second meeting this week. I think I saw Amy on there. Amy's also part of that committee. Mandy, several people. We have about a team of 15 on it, I think. So it's going well. And we just want to be able to answer the questions, those hard questions that people have that come up when you're entering a document. It's a good example, Mandy. I can't think of one off the top of my head,
Or you're even trying to find things.
or just even trying to find things.
Found that
Yeah.
staff at the beginning of this were so frustrated, they would just sometimes give up and not search for the document, not get to the thing they really needed to help them provide care. Yeah, incident reports about it, in fact, because they were frustrated that in a situation where they needed to take care of patients, they couldn't find the information they needed. So that was really the impetus of this, is that this great tool is actually becoming a barrier to staff doing their jobs easily. And so all of those standards help make it so that it was just as simple as we weren't putting in keywords for some of these documents, and because that wasn't what the leaders were told to do, and it wasn't easy for them to understand what to do when they were managing their documents. So all of this made it easier, but there's still some work to do in now transitioning all those documents that we do use all the time into the new standards and the formatting, so that it's really easy.
Yeah.
Or way to say it. We just want to make it super simple to find a tool that you need to do your job. It shouldn't be hard. It should take less than 5 seconds.
Yeah, I guess that's what it is. Yeah. We don't want somebody spending, and we had some examples of people spending up to 50 minutes trying to locate a document. It's just not, that's not just productive for us. So, yeah. So what was I going to say about that? We had the workshops. So we have workshops come out of that. We have just about finished the first round of those. We're going to do a couple of sessions for people that weren't able to make the first ones, probably the next 2 weeks, and then we will work on to session 2. And I see that going a good few months. So. Yeah. A 1.5-year project, but I think it's good work. The next one is the DNB audit results. So internal audits are tricky, and the DNB folks that were here, they were great. They provided some great feedback for us on steps for a successful internal audit. So we have initiated a project with Leanne Bolding. She's going to get us started. I think we have our first meeting next week on how we can start moving towards that. And we have an idea for that project. I don't want to spoil it right now. Yeah, we'll just leave that. But anyway, that's in process. And our compliance effectiveness assessment for 2026 goal is to perform an access review of encounter level permissions by user role and staff member. So I do have that in just a second in the 2026 work plan. I think that's something that's been needed really since we started with Cerner. So it's just taking time and getting the right people together and getting that done. I think we've talked briefly to Holly and Jeff in the past about this. We're ready. Moving forward with that. And before I do move on to my last step, I just want to thank Harry. Thank you so much for being our compliance board representative. He's at every compliance meeting. Thank you for that. Jason has been continued support for compliance, so I appreciate that. And then all of you, I do have just a general thank you to all departments for their daily efforts in upholding a high standard of compliance, but even that, I said that last year, I cannot do this alone. So, and we have a good program because of everybody here. So. Okay, now let's jump to the meat of it, the 2026 compliance.
Well, thank you for the shout outs too. And I think speak for everybody here. We really enjoy working with you. It's when I see your phone call, it's not like oh no, it's actually really warming to talk to you because you've already done all the research. You know what's going on. You're able to give a 2-minute brief on what's going on, and it's just very efficient working with you. Yeah, quite complex things.
Good, appreciate that. Very great. Okay, so if we can turn to the 2026 work plan. Could have made it a different color.
Get page 32.
32.
Yeah. So this is our goals for this year, and I think everybody has had time to review it, but I am here tonight to ask for board approval on the 2026 work plan.
Do you want a motion for that then to,
Yes, please.
I'll move to approve the 2026 work plan.
motion by Erica? Okay, second by Matt. Any further discussion on that? Hearing none, all in favor, say aye.
I,
Aye. Who will vote aye? No one is opposed? Passes.
Great, thank you.
Thank you.
Thanks for keeping us in line.
All right, moving on now to the CEO report. Jason.
Yeah, thank you. One of those I just call out on the work plan, like the 340B audits. I just came back from DC, and every legislator wanted to talk about 340B and what it's doing or not doing for our communities. And the manufacturers have been really hitting organizations hard to really increase that administrative burden. Following the insurance style is to make it administratively very hard to get much from that program. We topped out, I think, about $2.5 million a year. We're getting revenue from that program. We're down to over $500,000 now. So that program has just been estimated by the drug manufacturers. Met with Ray Campbell and Congresswoman Schreier, and both of them said for every little advocate that comes in, they probably have 3 manufacturer advocates come in to estimate that program. So
When we're over there advocating,
yeah.
how often?
And it's like, why do you always want to talk about 340B? It's because the reps just left. I mean, like they are just inundating them with 340B. And they're a little bit surprised how little we get from those programs anymore. There's also another creative route that the manufacturers do. So all insurance companies contract with a PBM, a pharmacy benefit manager. And for specialty meds, they often will refer all those specialty meds require them to get filled in one place. So like for regions for the PED, we're required to get them filled out of Arizona. And those drugs no longer qualify for 340B for our plans. So that's another area where it benefits the manufacturer to work with those PBMs have your scripts filled in another state to lose that. So very complex program. And I do not feel, or the people that have to do the audits for those programs it's a tough one, a lot of paperwork. So I think you're just learning the 340B.
Yeah.
And nobody really knows how the program works start to finish. It's so complex now. It started in 1992, I think, and it's just been layers and layers of complexity since then. So for what that's worth. My report on page 34, go through a few highlights. So we did just get a signed contract from Dr. Chabla. I bet Dr. Thomas will probably call that out, his report. So he's going to be starting in June with us for 1 week a month for urology, and we're still recruiting for the urology APC, but excited to see that come to our community. Just kind of wrapping up on here, been reporting on Midtown Depot, and we had that open house and ribbon cutting. So excited to have that beautiful service there. Hopefully everybody has came and or went and walked through it. It's beautiful. Erica was there. It's
Really
amazing. Yeah, beautiful new space. So thank you for the support to make that investment. And then Radio Hill. I know that Jennifer will give an update on the Radio Hill later in the packet, so I won't touch on that. Workforce exec team on Monday, we're gonna have our first just leadership retreat. So Nash Consulting is going to guide us through some team building on Monday. So I'm really excited for that. They've been tremendous support so far, and the exec here has really enjoyed working with them. So I think as we continue to invest in our staff, we have to invest in ourselves as well. So it's been really good. So thank you for the support there. We have visions, as we noted last time, we're going to be ending that contract and having all those staff come under the KVH umbrella. So that target date is May 1st, and just kudos to HR. If that's not your report, if you're gonna call it out, sorry for taking the thunder. They've been really busy trying to onboard all of these staff. So with that, you'll see our FTEs are gonna go up, our salaries are gonna go up, our purchase services will go down. So you'll see that flip flop on the financials. We will have more control to at least own the recruiting and retention for physical therapy. As an extremely hard recruit as well, but at least it'll be on us instead of pointing fingers at others. The buyout for that ended up being $70,000 with Rehab Visions up front, and then we'll have another $50,000 payout once we get speech therapy back to staffed. So when we transitioned with them, we had six FTEs, or these 6 FTEs of physical therapy. We're getting back less than 3. We had speech therapy. We're not getting any FTEs back there. We had occupational therapy, and that is still 1 for 1. I think we had one OT and one quota in there. We're getting those back, but it has been a bit of a revolving door. So we look forward to having that back under a wing. They had a non-compete with us, and we do still have one person who had applied for us and could not work for us that's still working with us through a little bit of legal matters around visions when we got them to work for us a year and a half or so ago. So it'll be nice to not have those barriers, really unfortunate barriers in a small community. And then want to revert back to the start of the packet and the foundation. We have the Bottles and Bites event coming up, so please grab your tickets for that. I think it's gonna be an awesome event that Laura's putting on, and it'll be our first one in Upper County, so I'm excited for seeing that. And I did send out a survey to all department directors. We're just going to look at revamping the Monday following board meeting. We always do an all department director meeting, and we want to really maximize the time that we have with all those directors. So 2 hours out of their time once a month is a lot of time for all directors. So it's, it's 100 to 120 hours of time that we spend together for each of us. We want to maximize their time. So got the results of that survey back today. Me and Mandy looked through them and look forward to implementing some changes based on our feedback. We're doing a daily safety brief now, and a lot of the last couple of meetings, there was a lot of redundancy. Well, we talked about that safety brief. So look forward to improving that efficiency and stuff. Time.
Jason, I had a quick question
Yep.
about this foundation event. Is this, I lose track of when these things happen usually, but is this in addition to the one that we're gonna have in Lower County, is it
Nope.
instead of?
Just instead of, so they're just doing one big event a year, and this year, instead of doing it down here, we're gonna do it in Upper County.
I see.
So
Okay.
this is the annual gala,
All right,
if you will. Yep.
thank you.
Yeah, I think it's gonna help bring a lot of clarity to that community as well, because they do have a large fundraiser every year that's through, they call
Life support.
life support. And they partner with a foundation in Bellevue called Medic One of Bellevue. So that is very confusing to the community because they actually think that they're providing donation to Medic One of Kittitas County, District 2. So I think just having this up there is going to help the community with some clarity of what our foundation supports versus what Medic One of Bellevue's foundation is. So I'm really excited for it, and I think it's a great opportunity to hit that population that I don't know that we've been hitting as much as we should. It's a very growing population, very diverse population. You have economic spectrum. You have the second or third home people, those who are really, yeah, I mean, their property values are going up and through the roof from the other ones. So, you know, that population has been there for a long time. So it's a very diverse group out there. So I'm excited to be leveraging some resources up there with the PTOT, ST, and then with this, and then expanding primary care down the road as well. Any other questions on my board report?
I want to say, I really enjoy all the ways that we are inserting ourselves into the community to positively impact it. I appreciate doing there.
Yeah. Yeah, and getting out in the community, it was pretty fun last year. Like we did all the farmers markets and the whole exec team rotated through joining some of those. And it was nice to connect with the community, and we're going to continue to do that this year as well. Hopefully my exec team will jump on some of those days as well. So
We absolutely will.
so I'm not the only one, but it was actually pretty fun to do those, especially Robert will join.
Yeah, the clinics.
Stacy does it. It
Marketing
was great.
marketing came and the clinics, I think, to almost every day except for 2.
Yeah.
So we've got a lot of clinic staff who will be
Awesome.
participating
Yeah.
too.
There's so many here that target our future potential workforce, which is really cool.
It's a good time for questions too, for a community to ask what we're doing. Yeah, it was really good. Thank you. I did just back from the AHA conference that was Saturday and Sunday, and then with legislators on Monday, Tuesday. Sorry, it all like blues together. And just had a really enjoyable time there. Learned a lot. It's really reinforcing of the stuff that we're going through is going through nationally. I do foresee, well, because everybody else is talking about it as well, 2027 and beyond is going to really revolutionize our healthcare. It's going to be different over the next 5 years. Introduction of AI, but also the introduction of less resources towards healthcare as well. So legislators all seem to want to know about how are you going to get costs down, but try to keep some access and briefly be so large spectrum there. The HR 1 budget bill anticipated from AHA to cut about $1 trillion healthcare a year, or at least over the budget cycle. And we're getting the $50 billion back. So people are like, oh, this is awesome. You're getting $50 billion. We will do huge things with that. For KVH, that's going to be about $800,000, which is less than half of one payroll. So in a year. So it's not very much. It's not going to change healthcare in mass significance. It might help us to like move the data center from the roof to a more secure location, but that's really about it. Not to be too down, but there was good things happening. The AI world is good. It's exciting. I think it makes everybody uncomfortable a little bit. But there's a lot of good things that will come from being uncomfortable. So just challenge us and the board and our teams to adopt those technologies and move forward into this new era. Any questions from that? I don't have notes like Matt takes, but I have some notes.
You can borrow his notes.
Oh, out there.
Anything else for Jason's report? Thank you. HR, Janine, what do you have for us today?
Well, our employee demographics remain pretty solid, about a 5% growth from last year. So not a whole lot of change there, but I think the biggest piece of excitement that we've had is the UKG rollout, which by and large went very, very well. I can't speak highly enough of IT's efforts, Ginger and Ed specifically, and Kelly in payroll, Allie, as well our analyst Jen Straight, Marlo Willis. I mean, it was just a huge lift for these guys. And doing that at the same time as meal and clocking in and out for lunch. So there was a behavioral change for clockings that we had to do at the same time, which was just a lot, and the support that we've had from our house supervisors to help shore up some of those workflows. It's been quite a ride, but I have to say that first payroll, we used to have about 5,000 touch points with Premier, just on an average payroll. We ended up with the first payroll we had with a 90% accuracy. It would have been 2%, but we had one change that we didn't realize we had to publish on. It was the BSN changes for the WSNA, but still 10%. This payroll, we are within normal payroll change request, corrections. But so 5,000 touch points prior under the old system. Under UKG, that first payroll, we had 1,473 touch points because the system's doing the work instead of people manually altering things. This current payroll that we just paid had 1,238 manually.
Coming down.
That's fantastic, especially in a world where the auditors don't want you doing a lot of time clock manipulations. And these are coming from the employees. There you can see an audit trail of what they requested, who approved it, and what change actually took place. So you can feel very confident about why you did what you did. And if you have an audit or if there's a complaint, you can show with absolute transparency what happened. This is also really important for the meal and rest break reporting as well. So yeah, it's pretty exciting. We're seeing some workflows and scheduling and how that relates to premium pay. So we're having some really good discussions with nursing. Our house supervisors have just been amazing in helping work through some of that process improvement. I would say, I think the schedule module, it's not as pretty as we'd like it to be in terms of just visibility of the schedule for the staff. So we're working with IT to see if we can't get an integration that'll allow us to export that into a format that's just more visually appealing for people to look at. That's been one of the pain points I think staff have voiced, and I quite agree. So we're looking at that. And then Preskini, we have that executive review scheduled for May 5th. And yeah.
So a few people had mentioned some frustrations with the rollout.
Yeah.
I believe your team reached out to people and do we feel we captured all those people, got them over the hurdle? And
I believe so, yes. And we still have we still have weekly meetings with our directors for process improvement. We still have aids that we're putting out for folks, and we're going to turn those into little videos for people. But yeah, I think for the most part, we've lifted it up. We've had a good rollout. Now we're in optimization. So now we want to optimize and see what we could do to how to connect with other systems and work smarter, not harder. But I think the biggest pain points were also rooted in perhaps some practices that we didn't realize were happening because they were happening in two different systems, and now you can kind of clearly see what's going on. So I think in terms of shift trades, for example, that really they shouldn't have been able to trade in the way that they were, resulting in premium pay. You can't even do that now. The system, we're putting in hard stops so that that's not even a possibility. It's not a perfect setup yet, but it's showing some gaps that we need to address, and we're having some really good conversation about what we want to do around that. And I do think what we'll be able to report out to our in our nurse staffing committees, I think will be just a little bit more fruitful in terms of process improvement. As we can pinpoint kind of where things are happening, when they're happening, we just got a little more detail in the data.
Anything else you want to push this direction related to HR? Okay, any questions for Janine?
To call out, it is Janine's last board meeting with us, so yeah. We'll miss Janine, so her last day is May 6th.
May 6th, yeah.
Okay. Yep, so wishing her the total best. She has agreed to stay per diem a little bit to just carry a few things through, but she'll be just communicating with me. She won't be getting inundated with email. I want to totally support her
I appreciate that.
at her next organization. So yeah, thank you for your help, and thank you for being able to stay in touch with you for some of these ongoing matters. Yep, thank you.
Thank you.
Yeah, thank you for all you've done for the organization. Appreciate it. Yeah.
Appreciate you so much. We will miss you and
Yeah.
wish you
Well, thank you.
100%.
Thank you. I've really enjoyed my time with all of you. I just appreciate all the support. Just a wonderful board, I have to say. Very, very supportive. So thank you for that.
Thanks. All right, so we will move on to chief information, Jeff.
So my report is on page 43. One of the things I'd like to highlight this evening is around, we just completed our IR planning, so incident response planning. So that's a multiple session for about a month where we go through a cyber scenario with our team. And this year we did sort of a hybrid where we did part as a tabletop, but other parts as hands-on. And so really this was around an incident response. We had to restore some workstations and servers through our backups, and really building and updating let's call our playbook, but our playbook on what, so, as technology changes so frequently, some of those things get outdated. So after a year, going back around and rewriting our playbook to match what's current. So we got that completed, and we do that annually now as one of our exercises. Between that, a security risk assessment that we do every year, and then we do monthly vulnerability testing as well. So multiple things always happening around behind the scenes. So, and then just highlighting, with as I mentioned in my report, with the Iran conflict, there are a lot of tensions going on, a lot of activity around cyber, not technically looking at, specific healthcare or hospitals, but they're looking globally as to, some huge infrastructure type incident to happen, right? So yeah, just any question?
I have a couple of questions.
Yeah.
It's good to see him first. So the first one, this is really neat how you, when appointments are canceled, then it goes right back in, and then it's able to reduce the no-show rate. So a no-show is not defined as one person not showing up for their appointment. It's defined as someone not showing up and then that appointment being empty or something, right? Because, so if someone else has routed in, it doesn't count as a no-show.
Actually, it still counts.
still
as
counts.
that.
It's a-
So a no-show is you didn't show up for your appointment, or you canceled in less than 4 hours, business hours of your appointment time.
So then
even
how-
if we
yeah.
bill it,
Okay.
still counted as a no-show.
So then so when you say it's, we've reduced no-show rates, is that just because people are being reminded, or is that,
I think it's
Yeah.
reminders.
okay.
Yes. So then before it was a set standard. We could not change as to when the reminders would go out. So, you know, if we said, well, we do it a week before the appointment and then the day before, that was it. You couldn't change that for any clinic specifically. And so now it's totally customized. And so you can get down to the individual and say, hey, we know this individual no shows quite a bit. So let's send them even more notifications that their appointment is coming up. So
You can do it by also different appointment types. So like, for example, neurology does Botox injections. We require a call and a confirmation because we prep all that Botox for you. And once we draw that answer in, it's only for 24 hours. And if you don't show up and we don't have somebody else come in, we have to toss it.
Yeah.
So it's given us a lot more flexibility in it, but it also gives the patient, it sends a confirm. And if you confirm it it will only send the reminder the day before. If you don't confirm that appointment, then you get another ask to confirm it 2 days before, and then another ask to confirm the appointment the day before. So it does
And
require
at that point, they still have not confirmed it, what happened?
nothing. We hope they show up.
Okay.
And we can actually go back and track, and did you complete your appointment, yes or no? Or if they say, I never got a reminder, we can look and say, we can see it went to your email. Do you want to set up text messages? Would that be better for you? It's been a huge improvement. The other thing it's given us is capability. If a provider calls out, we can just a few clicks and notify everybody on that schedule that we've had to cancel the appointment for the day. And we'll call you and get you rescheduled.
As a patient, I absolutely love the confirmation system and texting. It makes life so much easier.
But pointed out
Yeah,
too,
we're getting
it's
there.
like, they used to say, like when ortho was embedded in
It was
FME, it
generic.
would say.
Yeah.
Your
your
appointments
orth-
would have to
FME
go.
appointment, or
Yeah.
Cardiology was internal medicine, so they're a lot more pointed now.
So if somebody had a couple of appointments, they might be like, ooh, which,
Right.
yeah.
Hmm.
It's real slick.
And now at least you have the ability to recover, right? So if a patient doesn't show, and you never knew whether they confirmed or not, that appointment gets gone, right? So at least now in advance, you can recover from some of that.
The other question that I have is a softball one. So I'm always so proud of myself when I catch those simulated phishing attempts. What happens when someone clicks on a simulated phishing attempt? Do they just get something like, no, you idiot? It's a phishing, you know, or does someone call them? Do they get an email? Is there training? Like what happens?
Oh, no, you
Yes.
gotta go through training.
Yeah, so you get that response now, just but on the backside of it, it's all recorded, right? So we can get down to every individual and see how many times they've clicked. If they've clicked more, consecutively, then they get automatically put into a training program. And so we call it the clickers. And they get put into a special training program. And then so they got retested. Their testing becomes more frequently. And then we kind of continue from there. So
You want to publicly shame them right now?
Just trying to talk into like a billboard, yeah,
Yeah.
Clickers.
Yeah, every person has a security score in that program, so we can tell where they kind of sit in that as well. So
Oh,
yeah,
interesting.
it's a robust program, and now with the AI version of that, if you saw that, the AI version is a lot trickier because it is looking at every individual, what their preferences are, what type of emails they're getting, and so it starts to mimic some of those emails that are coming through. So.
Okay.
I did fall for one. I had to do the training. So I say, yeah, you fail, and then you get to do the training.
Jason said, emailed me and told me it was in such trouble, he needed a $50 gift card.
Yeah. So, our rates though, Jeff's team has done really good, and Susie compliance team, everybody partnering together. What's our percentage? Like in years, like 3%.
On the compliance thing.
Yeah, there's two versions. So with I call it the old school phishing, we're at 1.8%, which is well below the current industry standard of 4.5, I believe. And that, obviously changes as all the organizations start to get better as well. But with the AI versions, I think we're at like 6.4 right now. But it is a and, you know, it's true education. And so as we start to progress through these even more, we'll get down to that levels as well. So, yeah. But it's just awareness, right? So, and what we say you know, what we do it here at KVH is also preparing everybody for the outside world, for home, right? So you're getting the same emails, whether you know it or not, on your personal emails. So how do we train people for that as well? So.
So you don't have to go into a whole lot of
Yeah.
detail on this, but just a quick follow-up on that. So I know that you're doing a lot of work to sort of prevent any actual phishing attacks, you know, from sort of coming in. Every now and again, one gets through, I imagine, and someone clicks on it, like what happens? I mean, I'm not terribly tech savvy, but
Yeah.
sort of how, you know, what's the process? I know you do a lot to prevent.
Yeah.
If one actually gets through.
Yeah, so we have a program called CrowdStrike, and it is monitoring every single, we call it endpoints, every single computer in the organization, real time, 24/7. And so it knows if it starts to see something, basically fishy or should not be there. It alerts us, but it also alerts the company. And so a lot of times the bad guys will deploy something out, you know, on a holiday like Christmas or something where there's less people. So if it is a virus, it is able to spread through the organization undetected. Or like the weekends or 2 a.m. at night. But they'll get alerted and they have the ability to isolate that computer and the computers that it has spread to, and then let us know. So even if one got in, they wouldn't get very far in the organization. And that's something that's also happening in the background. And that's just one of the multiple levels of things that are in place here.
No, I appreciate that.
Yeah, well, we even know, so with this program, so if Jason goes down to surgery, it starts to, you know, hey, I'm just gonna use this workstation here in surgery. Well, we know that is not the normal behavior, that he doesn't access the workstation in surgery. So we get an alert because we know that's something that's out of place, right? So. Yeah.
Okay.
Yeah.
Great. Thank
Yeah,
you.
there's a statistic, I think I heard that healthcare is 5 times more attacked by cyber than any other industry. Well,
Yeah.
huge susceptibility
Yeah.
for healthcare,
Yeah.
and they do get through.
Yeah, and you know, just to be stewards, with the whole rural health as well, critical access hospital, we do participate a lot, helping, you know, all of the other hospitals too, because everybody's short on resources, so all the information that we get and others, you know, participate as well, especially around the whole Iran thing right now, it gets shared throughout the whole tier, you know, the rural collaborative as well, so.
Okay, thank you.
Anything else for us?
No.
Any other questions for Jeff? All right, then moving on to operations. Holly, Chief Nursing Officer.
My reports stand on page 47 through 50. I don't have any additions. I would say that coming up in May is Nurses Week, May 6th through the 12th. And so we have some events planned for nurses on those weeks, but certainly welcome the board to come and at any time. And if you would like to participate, and we're doing it something at night and also something during the day, but also we have some things that we're working with Crystal's team on for Nurses Week. So
definitely just forward to us
yeah, I will.
important bits and there's people's schedule.
Any questions for me?
Any questions for Holly?
Just a second what John said. I mean, I know the board members would be happy to participate. In anything
Great.
like that. So feel free to,
Send an invite.
yeah, let us know. Thank you.
Yeah.
Very good. All right, then we will move on to Stacy, Chief Operator.
My report starts on page 51 is the next third available. Only thing I'll call out is women's health and just talking about numbers. I had percentages on there because I think the percentages are absolutely amazing. But volume wise, 2024 total visits 27, 2026 in February was 597. Well, women exams, we only did 6 that month in 24. We did 47, and we are now asking primary care to send us their patients. So that's a huge success with access. And new GYN patients, we only had 4 new GYN patients in 2024, February 2024, and we had 91 new GYN patients in February of. So partnering with OBHG, we've got a couple APCs in that clinic now. We've got Dr. Waganek as a solid lead, has really improved access for women's health in the community.
We have another PA starting in the fall. When is?
Nurse
We'll see.
practitioner, it'll probably be in the fall. She'll take her test.
Yeah.
So we've got another student starting in there.
So somebody coming fresh out of there, starting a
Fresh out of
career here.
What were those two
Believe
numbers? You
arts
said
matter.
4 in 24?
4 in 24 and 91 new GYN patients in 26.
Just. Or 26.
Just in February 26 in 1 month. So I'm comparing February of 2024 to
Okay.
February of 2020.
Okay, so sorry, I guess I missed the February part. I thought that's only 4 for 24, but okay. That was probably more than that. Okay, that's really, really incredible. So it's not a typo then, that comma.
No, that typo, yeah, no, the percentages are
That's
absolutely.
a
amazing.
great thing to not be a typo.
Mhm.
Yeah. Wow.
And morale, the whole clinic's obviously grown, but it was pretty bare bones there after Dr. Dawson left. And I don't know if you remember her coming to talk and presentation, it wasn't looking good for OB here. And we very could have easily been like one of the other rural hospitals who have lost OB. So pivoting, getting that OBHG group to create a foundation. I think we got all 3 of them staff starting September of 2024. I think was when we got all them finally hired, and then we were able to get some PAs to support. So it's been huge effort to try to stabilize that. And it could have easily went the other way.
It was a great effort. And I know it's appreciated by the community. I hear that a lot.
And
There's good. To
answer any questions.
So
We get such positive feedback for the OBH. And even Dr. Waganek and the rest of the team. It's really exciting for that class.
You get the prize for having the best images. I mean,
I know, aren't those
this one, yeah.
I love those.
So we've done a lot of work in peds to make it a really pediatric friendly area too.
that came from some complaints as well of, well, I think it's the kids don't have anything to do, keep their hands busy. So patient experience complaints, and then us talking about ways to help them ease their time while they're waiting.
And we
I
really,
think they nailed it.
we really got away of things in the waiting room with COVID. And it
Coloring
just,
books.
yeah, it took us a while to
Yeah.
bring things back.
I would choose the room with the horses on it.
Yeah.
So very cool.
So we're able to do little video cameras that you swallow at this point?
Yes, the cap sound. Yes, they're about this big. That's why I wanted to include that picture. And you swallow it. It's a video camera that will do a recording and do a report. It's not going to replace colonoscopy, but it's a tool to use some specific cases.
No social media plug-in for it or.
No,
Yeah.
Put it
yeah.
on.
Bluetooth.
Watch it. You can't watch it live. It doesn't work.
Webcam.
Do you have to do like a prep before you do that, or you just like with a burrito, or like?
It definitely results in better pictures.
So
They're
you do
still-
prep
they're
and
still
then-
prep.
yeah, you can still.
They're still prepping patients.
It doesn't insufflate or fill the bowel in any way. So there's still nooks and crannies that don't get photographed, but it is
It's just another tool.
Interesting.
Exactly.
Yeah, interesting.
Is that AI supported in helping to identify things, or does someone have to sit there and watch? What is
Both.
8 hours of footage?
There is an AI tool
Was
that
born to
that
show.
assists the interpretation, but it is taking serial photographs and photographs then can be reviewed and put on a report. So it's useful, both from a human interpretation perspective and thankfully with the AI assistance in a much more timely fashion.
So props to whoever sits there and goes through
Yeah.
those images. Yeah. What a cool tool though.
Kind of fun to reflect back. So when we hired Jonica as the strategic projects coordinator, Dr. Thomas had a little work assignment for each of the candidates and said, there's this new thing called the CAPSO vision. Help, give me a presentation of where you would start to bring a program like this to KVH. So they had to, in the moment, kind of work through their thought process. And Jonica got the job. So
then she had to make it real.
she got to make it real. So yeah, pretty neat to see that go full circle. And I thought it wasn't real when it was presented.
I have to ask the question that maybe other people are asking, is this a single-use camera?
They do have to
They're
collect,
recycled electronics.
they do have to collect it at the end. Mhm.
Okay.
No, it is not re-sterilized in its native state. It's
Charge it again.
The Cleome therapy, how's that going up there?
It is going great. We could probably be busier,
Mhm.
so we can take more patients.
The community that shows up appreciates the facilities and stuff?
Absolutely.
Wonderful. Any other questions for Stacy? Anything else for us?
No.
Thank you.
When I called. I was up there at the event for that and I went there first thing as I got out of work, but I was just slightly late and I got out of my car and I heard this blam and I'm like looking for cover and then I look up and I see all this confetti drop. So it's the little popper.
Got there just in time.
Right.
It was a lot louder than I thought
It was
that it would be.
startling.
Yeah.
Yes, very
It's
celebratory.
total gunshot sound, yeah.
All right, so we're gonna move on to the medical staff, chief of staff, Dr. Hoppy. I don't see her online. Is it?
She's absent today. I'll represent her.
Perfect. So Dr. Thomas?
So on behalf of Dr. Hoppy and the Medical Executive Committee, you have before you a slate of 23 reappointments and 4 initial appointments, all of whom were reviewed by the Medical Executive Committee, and they voted unanimously to recommend approval to this body for privileging within our institution. So I'd ask the board for a motion, please.
We will do that. I just want to give a shout out to Shannon and her team. The amount of work that goes into putting these files together is quite impressive. And when we have a month like this,
Yeah.
they are staying busy. So
Great.
thank you to all of them. All right, so we're looking for, now, when everybody's ready to approve this slate of candidates.
I move to approve it.
Thank you, Terry.
I'll second.
Second by Erica. Any further discussion? All in favor, say aye.
Aye.
I too will vote aye. No one is opposed. That motion passes.
The only thing I'll mention here is I believe that at their next board meeting, Shannon's going to present on the credentialing process. Is that right?
I think it's the May one.
May?
We were just,
Okay,
yeah, we were like, was that May? Yep.
that's fine. So anyway, that's upcoming. That's partly instigated by me because I've been trying to wrap my mind around the whole process. Because I've been told how important it is the whole time I've been on the board, but I'm not sure I fully understood it. So I've been doing some homework. I mentioned this before. I'm putting together this primer on the credentialing process that I'll be sending out. And board members will have homework to do that. But I really appreciate the feedback on what I've been working on from Shannon and Dr. Hoppy and Dr. Thomas. So they've been very helpful on that. So anyway, just that's something to look forward to maybe in May.
Very excited. All right, Dr. Thomas, Chief Medical Officer.
Thank you again. My report begins on page 56. I have one amendment to make. You may notice that I transposed the reappointment and the new appointment numbers. That's 23 reappointments and 4 initial appointments. Otherwise, the only other addition is this late breaking exciting news that we have signed a part-time urologist who will be directly KVH employed.
Whenever I tell anybody that, you're supposed to say, where did you get a urologist? So, anybody in healthcare, like, where did you get a urologist?
Is there a
So-
punchline or is that just?
No,
because
that's just it, because they're
hard to find.
yeah, so we found one day a week or 1 week a month, and I'm really excited to have him, and we think he's the right guy to help bring the program here.
And he's the one who came up to the yet, and so he
Okay.
committed. I mean, it was a long drive for him to come up there, so.
He
And
is
it's-
his wife are both very committed.
And it was great to hear, he was going to Toronto to get some training on some very new technology stuff he hopes to bring here also, so.
Yeah,
Really
he's,
excited.
is always, seems to be always doing education and bring the latest and greatest to his patients. Efficiencies, being private practice, efficiency is very top of mind.
And he shared that so far his children are not following him into medicine. Doing their own thing, so, but no, great to have him, very exciting. Anything else from your
I
direction?
have nothing else
Chris?
to add.
Any questions for Dr. Thomas? Thank you.
Thank you.
All right. So we're gonna move on to finances with Jennifer.
Can I ask him just one more thing?
Please.
Can you talk about the residency, Sioux State every residency?
Sure. So everyone in this room is probably aware, but not everyone on the call may be, that we have in our community a rural training track for the CHCW residency, which is based out of Yakima. They match 2 residents every single year. So in addition to the residents who are based out of Yakima, after their first year is completed in Yakima, 2 residents move to Ellensburg and operate out of the Ellensburg-based clinic. We currently have a fully staffed clinic until the end of the month of June. The residency this year did not match 2 residents for the rural training track. So starting in July of next year, there will not be an incoming class of R2 residents for that position. In that timeframe, the residency is working on reorganizing their staffing in order to manage some costs. And we're expecting a significant change in the availability of access within their clinic. So we will adjust in order to accommodate that need in our community.
How does that happen that no one matches? Because I hear about candidates finding their match, and then there's organizations that want their match. How does that happen?
It's a great question. It's a very complex process, but at the end of the day, there is a mismatch of interest in specialties and available positions. Primary care is very difficult, and there's an awful lot of burden that discourages applicants, medical school graduates, from applying into primary care residencies. And to put icing on that cake, rural medicine is even more difficult in primary care, and so there is a shortage of people who are interested in practicing in a rural medicine capacity. There also is a backup program, so if there is a mismatch for a particular residency slot, there's an opportunity for residency to make themselves available in a subsequent round of matching. And this year, the residency opted not to pursue that subsequent round of matching.
I think I read something like 78% of all residency slots were filled this year or something. There was a large gap of total capacity and match. So
Yeah, it is, that number would vary depending on specialty and region geographically, but realistically, there is a growing mismatch in primary care. It's not improving.
and that definitely hurts us. It's only 2 slots, but it's 2 very significant slots. That's our physician pipeline. And when they go through rural track, especially local, that is like the highest probability of getting to retain them locally. We do have one that went through it that'll be starting with us at the end of this year. So
Sierra DeLay has come to us through that experience. Dr. Folkers has come to us through that experience. Dr. Stone, we've got a number of individuals who rotate through, and that's their first exposure. So whether they come as medical students with the residency or as residents with the residency, it's an important avenue for our making our brand known to potential applicants.
So our next chance then would be July of 28.
So the match will take place in March of 2027, and then they would first become available in July of 2028. Yeah.
residents also see patients, so it will result in less access that CHCW is able to provide. And they are going through the same struggles to recruit and retain as well. I think it's not really awesome news. There's a lot of great things.
Nick, but
We'll get them next
All
time.
right.
Yeah.
All right, so one more time, anything else for
No,
Dr.
sorry.
Thomas? today? All right, hearing none, we're gonna move to financial. I just want to say, Jennifer and I have been talking and meeting regularly. We've been on a couple months trend financially that's not optimal. And so we've been working, she's put a lot of effort into developing a plan to research some of these things. And she'll be talking about that during her report, but I appreciate the time she spends with me and is willing to talk as long as I'm interested in going through these things, helping me understand so I can share it with the other board members as needed and so forth. So with that, Jennifer, I will hand it off to you for this month's report.
Thank you. My favorite thing to do is talk about finances. So I'm sorry I'm not there, but I am at one of my favorite meetings, the CFO Wisher Rural Retreat. Learning a lot. And I have to say the whole meeting, my connection has been really good, and all of a sudden I'm pretty glitchy. So I might have to turn off my big fat head. if
It's
if it's a big fat head, I don't know.
You're in a
What?
small box. It's good news.
Yeah, feel free to turn
Oh,
off the
good.
video if that
Okay.
helps the connection. It's all about
Okay.
numbers.
So far it's okay. I just might be jerky.
Yeah.
Anyway, like John said, we haven't had the best start of the year, but I think we're on a better trend now. We are, let's see, sorry, lost my train of thought here. Against budget, we are about $3 million less than we want to be. Most of that is falling under revenue. And it's a combination of the adjustments being pretty conservative, but a lot of it is on the revenue side. And really our outpatient revenues, clinic in particular, as far as revenue per visit. So their visits aren't necessarily trending low, but revenue per visit is a little low there. Our emergency room volumes have been pretty stagnant. I did make a change in observation charges at the beginning of the year, and then all of a sudden we had an increase in observation. So we fixed that as we work with the UR team on getting our observation ratios a little better. They really should be, 1 to 2 or 3 inpatients, and we're running about 1 to 5 or 6. So 1 inpatient to 5 or 6 observation patients. So we're looking at that. We had a great discussion, I think, in our SLT meeting this week about all of this stuff. So that was nice. As far as the expense side, we're doing a little better. And year to date, our net income sits at $618,000, which is positive. But we, of course, wish it was better. Let's see here. What did I not hit? Salary. So one of the things that I really want to talk about is how over budget the salaries really are. And I think that's a combination of things, but we really will be looking at per diems, and all thanks to UKG, per diems, agency usage, all these extra premiums and overtimes. We'll just really have a much better visibility into that. And so I have hope that we can get back on track there. Let's see, are there questions about that? I'm trying to.
Any questions so far on the report?
Okay. What's going well? Radiology and lab, and as I said, total clinic visits are going well. We have some visits that are low and having a little trouble, and then some revenue to visit ratios are not what we would expect. We have a lot of new providers like we've been talking about. Are they ramping up? Are they seeing lower acuity patients? Stacy and I have plans to meet together a little more often to talk about some of that stuff. So that's a pretty fast summary. Are there questions about that? Otherwise, I'll talk a little bit about capital.
questions for Jennifer? No
Well-
questions so far. Carry on.
Okie dokie. So Capitol, the Radio Hill renovation project bid results came in. They had an opening on April 14th. As you most likely know, public hospital districts are really encouraged, unless there's some crazy reason not to, take the lowest bid. The bids, there were 9 bidders. They all came in pretty close in range, and so they did recommend to take the lowest bidder. That's a company out of Tri-Cities called MH Construction. I think you have a packet there if you want to look at the bids. You're welcome to, but we did have a letter recommending from our architect to go ahead with that company. So we do need, I think, just a vote, right? Because I don't see a resolution, so we would want to vote to move forward with that. They're ready to go and have about 120 days to do the project.
What was
But
their
I
bid?
forget. 1.35 million.
Yeah, so they range, sorry, I guess I'm the only one with a copy. So they range from 1.3, but as $1,340,410 for that MH construction, to the highest bidder CDK construction of $1,719,000. And in that range, there was 9 bidders, so they're all pretty darn competitive. Oftentimes VK Powell, Aldridge VK Powell, company that you're used to, they came in at 1,572,000. And Belsauce and Smith has also done a lot of work for us in years past. They came in at 1,530,000. The other ones I do not recognize.
So no bid from Walker?
No.
Sorry. Yep.
It is, it's not hospital based spec, so we got a lot more bidders and interest. So, yeah.
So what would you like from the
Yeah.
board for this? Do you want
A motion to adopt the current low bidder of MH Construction for $1,340,410.
inclined to put forth such a motion?
I
Do
would move,
Yeah, no, that's okay. I'll second.
move that we accept the low bid of, from MH Construction for $340,410 for the Radio Hill Phase 2.
Okay, so we have a motion,
Second.
second by Matt. Any further discussion? Hearing none, all in favor say aye.
I
I too will vote aye. Anyone opposed? That motion passes.
Thank you. And then I think
Thank
it's
you. And there. sorry.
Jennifer, correct me if I'm wrong. There is the bid alternates 1 and 2. I don't know the details on
Yep.
those bid alternates. Do you want to go over what those
So
are?
one
And
of them,
then we would ask the
Yeah.
board for that as well.
one of the alternates is for carpet instead of luxury vinyl tile or commercial grade vinyl. And then the other one is for it's in that package there somewhere, something with the roof, I think maybe. And that was a deduction if we went that way. So there's a little bit of questionable, what are we going to do when we get to picking specs?
What was the difference with, first of all, was carpet or vinyl less?
So the carpet vinyl upgrade, so it's upgrade to carpet from vinyl, correct? Would be 15,500. And then
think so.
I'll try to find what that was for the other one, but it's a deduction
It's
of
written in there.
3,600.
I'm pretty sure it's written on there somewhere.
Does the
Option
hospital have a
2.
preference on the carpet versus vinyl?
Did the team have a preference on do you want to ask the board for that? It's lap siding. Alternate 1, lap siding. Bidder agrees to perform the work described in bid alternate specifications shown for lap siding.
Is that an exterior related thing?
And then bid two.
Must be for
Bid two is the
replacement.
carpet.
I can find out more about those. One of them adds, one of them subtracts, and it's not gonna be for a long time before they get ready for that. So if you want, when we get there, we can ask for that approval.
The board members prefer to just give them the authority to make this decision and be done with it?
Fine with me.
Yeah, okay with me. Okay. Erica, what's your?
Yeah, I mean, if they prefer.
So I think it's one of those things where the numbers are contained enough that we would leave it to you and your team to decide when you get some more clarification, which one is best and not have to come back and wait for a decision here. I think would be logical in this case.
So just make a additional motion to approve admission to authorize the alternate number one and number two. Number one is the 15,500 addition for the vinyl and then, or lap siding. And then number two, 3,645 reduction for the carpet.
Did we authorize it if management feels it's necessary when they review the options? Thank you. They willing to try to repeat that motion?
I will make the motion he just. said.
There you go.
Motion by Matt, reiterating what Jason just said. Okay,
I'll second.
second by Erica. Any further discussion? All in favor, say aye.
Aye.
I too will vote aye. Anyone opposed? So that motion carries. We wish you well in your decision, folks.
Thank you. And thank the board. This is the first time we've used, what's the?
Design West.
KJC.
No, the other one.
KDA.
KDA. We've been using KDA for a long time.
Oh.
This is the first time, well, since I've been here, I think that we've used a different architect. I think that they've done really well. So thank you, Jennifer, leading us through the RFP process to select Design West. And then also this process for bid to get the lowest bidder here.
Excellent.
Yep,
Totally new.
thank you. I think they've given them
Better bid.
120 days to do the project, so we expect end of summer it will be done. At that time, the SEPA plans and everything will be done for the parking lot, and they'll just start the parking lot as soon as that's done, and that should be done by first snowfall or end of October.
Okay.
We'll be coming back for that. So that's that. And then we also had an EVS vehicle was approved by the Capital Committee. The van just doesn't fit their needs for EVS driving back and forth to Cleellum and bringing supplies. And so we did find a Ford vehicle with a government discount. The trick here is we want to trade in the van, which is on a disposal, and I guess we can get to that at the end of my presentation, but we will be asking for resolution to dispose or trade in that van. So
And the
that
net cost
was
would-
$23,000.
Right, so we're trading in the vehicle we have, and it's a brand new vehicle that we're getting. Is it Ford?
It's a
Explorer
Ford
or something?
Explorer.
Yes, van was
Brand
bought
new.
maybe 5 years ago. And the idea of buying the van was they would get to put their big Zamboni in there to move it between building to
Mm.
building. They've never put it in there. They've never needed to move it. They
Mm-mm.
actually can't get it in there either. So the staff are not comfortable driving that vehicle. It's like driving a toaster oven down a very windy highway, and it's 2-wheel drive, and they don't feel safe in it is a very main reason of getting this change.
Yes.
It'll be more fuel efficient. It's also a Ford, which will also help because we have the dealer in town that can be serviced. Currently, if the van breaks, we have to figure out some place to take it to and send staff and have it sit there out of town for a while. So we're supporting our local dealer and getting it done here. Okay. Color.
And you're looking for a motion for this to move forward?
Well, we can
Or
do that,
surplus
we can do
edition.
that, but the resolution is at the end of my end of my presentation. so I could just come back to that.
Okay.
Yeah? Okay.
Yeah, that's fine.
And then just one other thing, the master facility on-site planning is scheduled for the week of 18. There's been a flurry of meetings being scheduled this week and information going out. And I think you have it on the agenda to talk later about board involvement, Jason.
Yeah.
Okay. So we'll revisit that. Just kind of back to my summary a little bit. I learned last night that WISHA got their contract from the HCA for the RHTP funds. So those rural transformation funds that we've been talking about. They finally got a contract for that. So that turnaround should happen soon. I've made Crystal aware as soon as I knew that we will be having to apply for funding for that. And I think the request is going to be for our boilers, probably.
So
So
that's
just
that.
information.
We're just thinking about $700,000 to $800,000 from $700,000 to
Yeah, we don't-
$800,000.
Yes. Let's see here. Just a couple more talking points about sort of how we're going to get back on track with our budget. I talked about the per diems and the, contract staff. We've asked everybody to really think about whether you need to replace somebody when you lose somebody. Looking at those observation charges, we have this new CDI person who looks at charts and coding, and I think he's going to be looking at the clinics. We're going to look at referral patterns and all kinds of fun things like that. I have, like I said, hopes. We actually budgeted for our revenue to be 8% higher than last year, and we're at 7% right now. So I think we're on the right track. Questions about that?
No
Can you hear
questions?
me as I'm talking? I really hate being on Zoom, so I apologize. We can go to the key stats page and just point out just a couple things that I think I've been pointing out all along. Inpatients kind of flat, but the most of our revenue, I'd say loss, is in surgery, in rehab, as we talked about already, and then we're suffering a little bit from volumes in the ED and our urgent care. So more to come on that. Are there questions about that? And then I'll just
We're on
zip
page
through.
60.
What's that?
I was like confirming what page we are on to make sure they're looking at the right
Oh,
chart.
I'm
So,
going fast, aren't I?
nope, you're fine. Any
All right.
questions about some of those numbers, Chief? No, I think we're good. So go ahead and carry on.
Okie dokie. I'm gonna just skip real quick to the statement of revenue and expense on page 63. And I've already really talked about most of these things. But let's see, what did I want to point out? Oh, I also learned that some of our other operating revenues, thanks to the GASB people in the back room that keep coming up with these wonderful rules for us to follow, are going to be asking us to reclassify some of our other operating revenue down below that operating income. So you may be seeing some changes there, of which I will point out when they come.
Okay.
Yep. I thought you had a question. And then just one other thing, down at the bottom of the income statement or the statement of revenue and expense, under unit operating income, we had not been allocating benefits across the clinics and the home care for the first part of the year, and they did a true up in March, so it looks little under overstated in March, but the year-to-date numbers and breakdown there are correct. Want to point that out. And then I don't know if I have too much more to say about these statements unless you have questions.
Any questions about the remaining charts? I'm not hearing any questions from the group, so you're free to carry on.
Okay, anything, John, that we talked about that I didn't mention, or Jason that we talked about that I didn't mention?
No, I just appreciate Jennifer had a slate of some ideas to help bring us back to budget there. She brought to me last week and then she talked with the exec team on Tuesday. I wasn't able to join for it, but we'll be working on just really trying to pay attention to all of our numbers and support access and remain steady in the months and years to come.
Yeah.
January was not awesome. February was a little bit better. March was a little bit better. So we seem to be in the right direction. Yeah.
But I appreciate your willingness, interest to immediately start digging into where are we slightly diverging? Why are we diverging? What can we do about it to get it back on track? So I know you'll be working that behind the scenes and corresponding with myself, and I'll be, looking forward to those discussions as we come up with solutions and whatnot. So.
Great.
We spent a lot of time
Will?
we spent a lot of time going through some of the other reports that haven't really Jennifer hasn't been introduced to in a while, or ever. So that was good to go through one-on-one as well. Scott was out for a period, so we got to really dive into some of the weeds of our reports.
Yeah.
It was very educational for both of us. Yep.
Excellent.
Yeah, it was a good, horrible thing. It's a very good, horrible thing. So, if there's no more questions, I just have three actually resolutions. One we already talked about. The first one is, apparently when Kelly, I don't even know how to say her last name, left as auditor of the district, we did not replace Kelly as the district internal auditor. And this resolution is just naming James Sivanan as that internal auditor, which is pretty standard in a public hospital district to have your controller as the auditor. So we are asking for that.
Do you want us to talk about all these and then vote, or do you want to have us vote on this one right now?
I don't have a preference. We
Okay,
can do
well,
it
why don't
however
go
you
ahead and
want.
why don't you talk about the next one, and then we'll have them all covered, and then we'll vote on them.
All right. The next one is authorizing use of the MRSC rosters. I think you as board members are familiar with the MRSC website with all of the governing education information. They also host a roster for small works and for procurement activities. So they have bidding help there. You don't necessarily have to use the bidding, but you can use the roster for selecting vendors for projects. So what we do is we will put out an ad saying, if you want to be on our master list of vendors, then go here and register. If we come across vendors, we ask them to register, and that's just where all of our procurement stuff and information goes through. So that's a resolution asking the board for permission to do that. I think the cost to do it is, Mandy, $200 a year, something, but it's
It's a little bit more, but
it's
it's not very
it's
much.
it's a wonderful way to stay compliant with your procurement and all the rules that we have to follow as a public hospital district. Questions about that one?
Questions?
We're currently having to maintain our own KVH specific roster. This allows us to basically use a state roster. The state's managing it, the state's keeping all the vendors, doing all the background work to be able to put them onto that roster. Whereas what we've been running a ad every January, asking if any vendors would like to apply to be on our roster, then we would have to vet them, add them to our roster to select from for small works. So
So if we do the state, we're guaranteed compliance. We're
yeah,
They were.
Yes.
So it sounds like
And
it
it-
takes a lot.
reduces some
because
lifting
it's
that we have to do. Okay.
Yeah.
All right. Anything else you want to tell us
Yeah.
about any of these before we begin voting on them?
Nope, and then there's the surplus one we already talked about, and that is it.
Okay. Very good. Well, let's get to these resolutions and then we can see if there's anything else. So the first one we have is resolution 26-03, the appointment of the district auditor, which would be James. Is anybody so inclined to make a motion?
I'll move to approve that.
Okay, motion by Matt,
Second,
second by Erica. Any further discussion? All in favor, say aye.
Aye.
I too vote aye. Anyone opposed? That motion passes. Next, we have 26-4. This is the MRSC roster we just spoke about, having the state provide us with the list rather than us having to develop our own. If anyone's so inclined, entertain a motion.
I'll move to approve.
Motion by Erica,
Second.
second by Matt. Any further discussion? All in favor, say aye.
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 I too will vote aye. Anyone opposed? That motion passes. 26-05, surplus personal property. This is trading in the vehicle we have for a new Ford Explorer that'd be maintained here locally. Approximate net out of pocket of 23,000. Entertain a motion if anyone's inclined.
I move on that one.
Okay, motion by Terry, second by Matt. Any further discussion? All in favor, say aye.
Aye.
I too will vote aye. Anyone opposed? That motion passes.
That was very efficient.
1, 2, 3.
Oof.
Jennifer, anything for us, anything else
Thank
for
you.
us on the finance?
I have nothing else unless you have questions for me.
Any other questions for Jennifer? All right, have a great rest of your conference.
Thank you. I will turn off my camera.
All right, thank you.
See
Bye-bye.
you when I get that. Bye.
All right, so now we're moving into a bunch of board-related stuff we're gonna be chatting about. Very happy to take a pause right now. Anybody that doesn't want to listen to the board talk about a whole bunch of just board rules and things like that, you are free to go home and enjoy your evening. And you're
Nice out there.
100% welcome to stay if you want, but
Happy birthday.
we'll pause for a minute or so for anybody who wants to sneak out. And again, thank you everyone for the time and effort you put in to get ready for these meetings, so.
Oh, God, you did.
And so, something's down, Matt, if you want to start the signatures. Or if you want to sign this one, it's just you and me for this one.
Need you. Bye, Janine. She's on vacation for a little bit.
I saw her today.
She was here for a little bit and then she took off and yeah,
I saw one here, but it had coffee.
That should be.
But I couldn't- when they come back,
Yes, okay, it'll be a whole little.
Yeah.
I'll do it. when it's-
Great.
Nope, she's here until Monday.
She just mentioned that the meeting would not be attended.
It would be nice.
Well, This is correct.
Okay. It's myself and Bob.
But they didn't tell me no.
All right, so let's get ready to move on to, this one has the two signatures, Harry and myself.
Got it, okay.
All right, so moving on to old business. We're talking about the JJCA master site work, which has been falling under the, what we used to call financial sustainability, but maybe renamed now. Jason, do you want to lead this and tell us
Yeah.
what you're thinking?
Sorry, I should have asked Jennifer to stay on for a minute. If she wants to jump on, you can text her, but as we've worked through just some facility stuff in previous, it's nice to have a couple of commissioners a little bit more tied to the conversations. And previous years, we just use the Financial Stability Committee is what we called it, and Bob and John were on that. You know, it's just kind of an extension of the Finance Committee. We went through iterations of just talking about this stuff during Finance Committee or having a special meeting if we needed. And then if you recall, we would really just kind of report out at our board meetings if needed or the retreats. So I just wanted to ask the board, as we go through this process, would like to continue with that same status. To have a couple of board members a little more connected, or we're doing something different, but it would be nice to have Jennifer, what she used to have was a building committee with a couple of board members on it, which we used to basically do the Finance Sustainability Committee. So just wanted to talk about that. Okay.
So just, sorry for someone, for me, who's a little slow here. So is the options are just reporting out, so handling this all in the Finance Committee and reporting out there, we're having a separate group?
To have a couple board members, yeah, yep.
And
So,
what
yeah.
is what's the separate, this is separate committee's name would be what?
Building committee.
Could be building committee is what Jennifer had at previous organizations, that's what it was called.
All right.
And the goal of the board members participating in this is what?
Just to ask questions, talk through the process, help us, you know, from the community's perspective, as you represent the community and the commission, that we're on the right place, that we're informing the board along each step appropriately, seeking that feedback along the way that we might need as we aim direction for the master site planning. So at what points do we engage the full board versus, yeah, just the.
Yeah, and I interpret it just less filtering to get information to the board if decisions, you know, need to be quicker to make sure we're not going down a path that suddenly is going to have to be undone. So.
Yeah.
I mean, so they, I
Hi,
mean,
Jennifer.
Hi, sorry about that.
No worries.
My fault.
I'm
We're
on my
talking about
phone now.
we're talking about the building committee. Sorry, I'll do a quick
Oh,
1 minute recap. We used to
Yeah.
use the Finance Sustainability Committee, which was kind of an extension of Finance Committee.
Yeah.
To do what you explained as when your organizations, you've had the building committee to do those. So just put that
Yeah.
question to the board of would they like to have two commissioners, a commissioner, two commissioners, really be a little bit closer to the master site work and the building work. And then that group would be a lot more informed along the way to help present to the board of the work that's going on.
Yeah.
Kind of behind the scenes. I'd still propose that we do a retreat as well in the summer as we've done each year's past and really go into depth of our current programs and changes and get some direction. So we didn't have any changes there. You want to say something,
Yeah.
Jennifer?
Well, so when it really becomes important is when you start to talk about specifications and your you know, your colors and all that stuff, and to be able to have some board members that have the authority for the board to make those quick decisions. That's really where I've noticed it's helpful. And also, like you said, Jason, to just be a little more informed along the way. It can move pretty fast sometimes. So that's kind of why.
often with this committee meet and all likelihood.
Just as needed, right, Jennifer?
Yeah, I imagine, you know, if we move forward with building, there'll be a time where it's pretty darn busy and maybe even a weekly thing, but not now.
I mean, I think it's a good idea as long as there are board members who are willing to do it.
Yeah.
John and Bob are on the Finance Committee. It seems like you guys are probably the kind of natural fit, although that's not necessarily the case. I guess I would ask if anybody on the board has the time and inclination to do it, it'd be fine.
I think originally we thought it would be just a natural extension of finance, but we also appreciate everyone to hear their point of view and see if maybe somebody thought it'd be a better fit for them. So we wanted to have an opportunity to.
I'm fine with you with Bob, if you're interested at the time.
Bob, do you not want to do it? Speak now.
Voluntarily.
Yeah, I haven't asked his schedule and busyness, but should we have like an alternate or deal with that when the day comes or something?
But when the day comes,
Yeah.
we're all very reachable.
Yeah.
And we'll be bringing updates to here along the way too, and everybody can ask to, be further updated, to talk about something, to give input. So we want to make sure everybody has time for input and working through each step.
Yeah, and then I think once they do the master plan, they usually present some kind of sketch when they're done, but they're thinking they're gonna go away and do a little bit more research and work around the schematic designs, which are really just like the bubble diagrams, if you will. And then they'll come back on site and we'll make sure they come for a board meeting so they can present that and you can all be available then. And then, like I said, it won't matter until and when and if we decide to really move forward and build, right? So there's time.
Yeah, and obviously any decisions for building capital would come to the board.
Right.
So
Yeah,
we're-
anything
yeah.
related to spending money would be
They just have a couple more board members that have been a lot tighter to that process along the way to say, yeah, we did
Yeah.
work through this, we worked through that. To be not
Yes.
representing the board when we do come for those asks.
Yes.
I know that some of the topics like we talked about in the finance and sustainability committee, one of them is like we assessed all of our clinic space, how many square feet, or did visits each per square feet one they were putting out, really kind of worked into those stats of things. And we go to the full board for direction.
Bob loves talking about square footage.
Yeah, who doesn't?
Let's let him do
What's the cost per square foot there?
Let's let him enjoy himself.
How are you feeling about this?
I'm good with that.
Okay.
Yeah.
Barry?
No. I didn't, here we go, there were more things.
Okay.
But thank
So
you.
I
Barry.
think we'll just make it part of
Keep going
finance for
forward
now,
as we
just
go.
kind of status quo.
Grateful for your willingness to take that on as well.
Well, I'm not measles at the school district, so I got more time than you do. So, does that answer the question you needed for that topic then?
Yep, yeah,
Okay.
I don't think we need a motion or anything, just really the question.
Just confirm that we're good to
Doing
move forward.
as we were doing with that.
Okay.
It was financial sustainability, now it's financial strength pillar and the board sponsors under that.
So are we free to let Jennifer go about her evening then?
Jennifer, you're totally welcome to jump off.
Yeah,
Oh, thank
Thank you
you.
for-
We're going bowling.
go do it.
But
Have fun. Thank you.
Thank you.
that is
Bye.
the best conference and I'm jealous that you're there.
Yeah, it is good.
Go
Thank
enjoy.
you,
Report
everybody.
back later.
Okay, thank you.
Okay, bye-bye.
Bye.
All right, so we're gonna move on to new business now. Part A is board self-evaluation. It's just that time of year when we start talking about what sort of evaluation we want to do or
Start talking about ourselves.
start talking about evaluating ourselves. So I just open it up to the group here. What are your thoughts? How would you like to tackle this year?
I very much appreciate hearing from others within the organization and their what they appreciate and what our opportunities for improvement are. I would like to continue with that. I'm not a big fan of 1 to 5 rating at all. I just don't think it's very actionable.
That's the same thing I want, that Erica had said.
So everything she said, you're giving a second to.
Yeah, I know, because I'd like to have other people talk to about us and all that stuff too, like Erica said. I guess it is a second.
I agree. It's good to get feedback from people in the organization, especially the people we work with on a regular basis in the SLT. I agree that, yeah, this 1 to 5 scale, I think some of these things we've got and they're tailored, some of these assessment mechanisms, whatever, that we've had have kind of been tailored toward an appointed board as opposed to an elected board. So it asks like, what are gaps that you need to fill? Well, I mean, people in the community pick the members of the board. We don't have anything really to do with that. So I think I don't mind having some questions to start a conversation as opposed to a 1 to 5 scale thing. But I would like them to be tailored to like an elected board as opposed to, so we ask the right questions. So I agree with both of them, but with that addition.
Okay with some of those so long as we get the long form. It can be aggregated, that's fine, but I just really appreciate getting a deeper understanding of our perceived effect.
From the leadership team.
Mhm.
How do you do that? Like, what's the process for getting feedback from the leadership?
The last year was the first one that I was involved in, but my understanding is the same as what we've done in years past, and we just had a hour discussion with the exec team and we'll be taking notes and then summarize those notes anonymously to the board. So happy to do that. We could also do just an opportunity to do like a survey monkey and then summarize all that as well. And it could just be open comment because it might not be something that people want to openly because it's not anonymous then if Dr. Thomas says in an open room with me there or something. So we could also seek some anonymous feedback and then
I like that.
and then summarize that as well. If you're open to it. The one that I was a part of last year, which was again kind of reason why I really encourage the board to do like a full 360 and get perspective outside as well. It ended up being focused on like one topic versus kind of forced conversation among 4 topics. The exec team met last time, so selfie about.
Started with a survey monkey without necessarily, I guess, I don't want to say the conversation is being led, however, if somebody mentions something and then that's what gets the attention.
And then
So
that's
if
the
everybody has an
flow of the
opportunity to just
conversation
take
all the
whatever's top of mind or important to them
Yeah.
before they get together for the.
I could also ask maybe Matt Ellsworth if he has any tools or questions or anything like that guide board self evals for elected boards. I don't know if that's been requested before.
I think he's the one where we got the really long, like 1 through 5 scale of a couple of years ago.
Oh, really? Okay.
Did Michelle facilitate the conversations last year?
Michelle scribed it last
Right.
year, yeah.
Who facilitated?
Nobody facilitated, we just in an
So,
open room.
led.
Yeah. And that's where I see it just kind of can evolve to one topic.
I think it's fine, whatever process you think is most productive is fine with me. I don't need to micromanage sort of how you do that.
So we can solicit feedback and give to the board and then.
But I think you have the right inclination that it's good to get some anonymous feedback. What we've done, when we've done evaluations of, I think CEO evaluations, we've gotten enough feedback from people and then we summarize it and then get them in a room and talk to them if there's anything we need to revise, that's worked for us.
Yeah. Yeah, would it be okay if I could get what Matt provided before too? I would just be curious to see what that is.
I think so.
That, if we had that could actually, then we could facilitate more conversation than just blank slate. What are you guys feeling? And then whatever the flavor of the it being hyper focused on that. So if I could get what Matt had, I could probably facilitate that.
What was one of them?
Copilot could probably turn those into open-ended questions.
Yeah.
Make that easy.
I'll do
Yeah.
some stuff.
So we can come up with some ideas there.
It is it's kind of an odd process, like I said, because none of us can be removed. Nobody can be added, no one can, so it's really just about changing our behavior if it's not going so well, or reinforcing good behavior, which is nice, but I'm not sure anybody ever actually changes. So I'm not really sure. It's a good process, but it's a very different thing with an elected board. I'll just put it that way.
I feel more optimistic than you. I think that there have been suggestions that have been taken to heart. Maybe they're small, but I think that they are meaningful and they're recognized. And I also think that what we choose to do with it is one thing, but also giving people an opportunity to contribute their thoughts and know that we do care.
Yeah.
I think
it's good to listen to people's opinion. And I think we should get them.
Are you saying you're not going to change?
I'm just saying no one changes in response to it. I mean, that's more of a pessimistic view of people in general. It's not about this board specifically.
We're just over here to balance each other out.
Yeah, you're always the optimist and I'm always.
So the main thing is I don't want the hospital to spend many resources on solving this problem. I think a generic survey monkey where people can do some anonymous things. Ideally, you get people in a room, let them talk, see what comes out of that, combine those two ideas, provide it to us, then we would call a special meeting where the five of us sit down and go through all these notes. And like Matt says, I mean, you're stuck with us. But as fairly decent humans, I mean, if somebody identifies something I can do better, I will try to do it better until I run out of gumption and just revert to my old self. So
It wasn't by you specifically. I was talking about myself.
Yeah.
So, yeah, I think like Erica says, it's informative. And when we do feel like we want to collaborate and try to exude that, if people have useful things to say, I would like to hear them. I just, again, I don't want to use a lot of resources because again, there's very little we can do. If somebody says, yeah, so what, you know,
Yeah, we don't want to hire a consultant.
yeah, we're not fixable. So is that all kind of resonating okay, or any
Yeah,
pushback or anything, or?
No, I think just the request would be, we'll gather some materials, some questions, and I'll facilitate a discussion. We'll get notes. We'll very likely do a survey monkey. Could I run that kind of structure by the board president between now and before delivering that, just so I can, this is what I'm planning on asking these 3 questions. How's this sound?
Yeah, I trust
Or
John to be able.
But I'll see what Matt has and I'll see what my AI friends have. And then we'll have something. And did a survey monkey 2 weeks ago, so. Maybe just had that, so. Yeah.
When are we hoping to get together to discuss results?
Really depends on when you feel the timeline is to realistically go through these steps you just outlined.
We should be able to within, you think?
You
know my
For maybe
calendar.
the next month,
Okay.
just because there's a
That's
lot
good.
in JJCA here for.
That's right. So let's shoot for maybe towards the end of June.
Yeah.
Let's have-
And would you guys like to do it like a special board meeting or have a long, I don't know, can we do this in executive session or is it?
I would prefer to meet separately,
Okay,
just to have my brain be
just about that.
tip top shape. or-
Yeah, it's exhausting by the time we get through this meeting to then have a soul searching,
Yeah,
get.
Didn't it go
down
just
by-
straight to this?
I think they go just straight in because they're.
Would it, I mean, we're all gonna be together at the end of June in Chelan, right?
I will.
that's still a
No, I
question.
don't think everybody will be.
Oh, okay. I forget it.
Who else going to that? I'm not.
I don't have enough.
think I am.
information yet to determine.
I think I have,
Am I
I
going?
think Matt and Harry are the only ones that are confirmed.
Cause you didn't, the hotel and stuff, the Campbell's was all sold out. So you got the alternative, right? And just made it feel like we're not wanted there, kind of that sensation.
There'll be a lot of other people at that hotel too.
Yeah, and that was actually went into July this year, right? It was.
Yeah, it was the,
I think
Last couple days
the
of vacation.
very end.
Yes, oh, yeah. through
yeah,
July
because that's when I'm probably in Alaska.
Yeah.
And then I don't know if Bob is planning to.
Well, I mean, if we're not all gonna be there, then we can just do it here. That's the
Yeah,
only
so
reason
I don't plan to be there.
That's the only reason I raised it.
Yeah, yeah. So
Okay,
are
so
we all gonna be in Denver?
I don't know. I don't know what people are doing. with
No
it.
one will tell me.
I only know
You know
about
how
me.
many people are going
Sorry,
to Denver?
Denver for the,
and I
Yeah.
voted on
No.
in July.
Well, everybody got voted, anybody.
Has anybody told you they're officially going to Denver? Mandy? I can't,
I think one, I think. that's
okay, because you
Denver.
keep staring at me like you're not
No, I'm
there.
trying to remember which is that the leadership one?
That's the leadership in Denver.
The AJ.
Yeah.
Yeah,
So only one person's officially told you?
yes.
I'm still kind of 50-50. I'm
I hate to
trying
be
to a
so.
little bit deciding if everyone's going, I don't know that's economical. I don't know that all 5 commissioners have to go and bring back the same information. So I'm
I
trying to
know that
so-
WISHA still intends to do the September one for advocacy in
in
DC.
DC.
And I likely won't attend that one, so that just put that out there. If somebody wants to attend that too, I think they're good to go too, but from what I've heard, those ones are pretty.
Before the midterms, that's what the point is exactly, but.
Yeah.
There wasn't very many people.
Yeah,
so-
that one's been frustrating for me because again, there's been some meetings where there's 40 people from
Yeah.
which are in the room.
This was, I was like.
And the
this-
reps are just overwhelmed. They're just like, there's so many people trying to get
Yeah.
my attention.
I think the AHA annual in DC is gonna be much more valuable. I don't know that anything's gonna get, I mean, what are you gonna do?
Yeah.
What's gonna get done in the fall?
Yeah.
Nothing.
When do you need to know from us about Denver? Isn't there some?
I don't know the deadlines off the top of my
Okay.
head.
You don't keep it up there?
I'm a good boy.
All right, so.
We are, we are trying to really. And the board's always diligent about the budget and spending and all that stuff too, so we are trying to encourage staff. That, every other year, out of state travel, those kinds of things, so. Split those things up, I think if there's a few going to Denver.
I haven't gone to state in almost 3 years. So I can do my part.
Yeah.
So we will hopefully meet in late June to discuss the findings. And you
I
are
think-
check in with John about the tool.
Yeah, we'll come up with some, Mindy's really good to
Yeah.
chat to you guys and get a date for
Once
proposed special
they're
board
close.
meetings.
Sounds good.
Yeah.
Erica, don't call John a tool. Thanks.
Oh, Matt, you know that you're gonna pop up with something a little questionable at the end of the meeting, right?
Yeah, well,
So do we have enough information on that? We close that discussion, so we'll kind of. I'll work with you. You'll give me a sense of a timeline once this is underway.
Yeah.
And then we can start targeting the date to meet for the results when we feel they're gonna be ready, so.
Mandy will work on timeline, I'll work on a draft of
Okay.
facilitation.
Perfect.
That's great.
All right, so let's move on to board bylaw, and at the end of the packet, there was, so this is the red lines have been removed, and then this is, so I looked at it, there was several little changes I wanted to make to the red line draft. And I also thought,
So nothing's in the packet. That was the.
okay, so that's, oh, it must have been the old packet I was looking at that had it, okay. Okay, so
They were just
the agreement was, I had some stuff I've done mine, but I haven't turned it into you yet. Was for each of the commissioners to have an opportunity to go through and make any of their own little notes related to either the red line version or the summary version. Before it became official. And then you brought up a good point. We should talk about the president versus the chair thing, which I think could be part of this whole
Yeah,
thing. So I do it once. So Matt, I don't know if you want to talk a little bit more about your thoughts on the president versus chair idea.
yeah, I looked this over and I like the changes. I don't have a problem with the changes, but I thought that since we were changing the bylaws anyway. Talked a few years ago about making this change of the title from president to chair. And of vice president to vice chair. We had talked about it, but hadn't done it because it would have required a change in the bylaws. We just didn't do that or want to do that. But now if we're opening them up anyway, I think it's a good idea to change it. There are two main reasons why I think it should be changed. One is and having been, past president of the board, I think it sort of gives people the wrong impression, like, obviously, anything we do can only be done, as a whole board. Any decision we make done as a whole board. The notion of a board president, I think, gives the impression that there's one member of the board that has more power than other members of the board, which is not the case. The main job of the head of the board, as I understand, is obviously to run the meetings, but also kind of corral the board, get them on task, organize, decisions that we have to make as a whole. And it seems more appropriate than for the title of chair. The other reason behind it is that this is more common practice to talk about board chair. When you go to Chelan and you meet all the, other boards, board members, they have a chairs retreat that they go to. It's called chairs. Most of the public hospital districts have chairs, not presidents. And Matt Ellsworth confirmed that most boards have chairs and vice chairs. And any ones that have had presidents have sort of moved in the direction of changing. So it's just those two. I think it gives the wrong impression, and it would be more in keeping with what's standard practice. I mean, I'm not going to die on that hill or anything, but it just seems like an easy change to make while we're making changes to the bylaw.
I like Hill.
Terry, do you want to defend the president role or do you like the idea of a chair?
Well, historically, it used to be called a chair and we changed it to a president. And I like having the main person that does all these meetings known as the president. But if the other commissioners actually vote to change it to the chair, I'm not going to be upset about it. But I like the word president and vice president because I think people in our community know a little bit more what that means than a chair and a vice chair.
But can you appreciate some of Matt's thoughts? Like a president usually defines a unique position where in our organization, we're a whole board. We just need, we rotate through who runs the meetings and has that time to shoulder it. So can you appreciate why he's thinking this would match the other organizations similar to ours?
Yeah, I know the other organizations say chair or vice chair, so I'm not gonna be upset about it.
No, it's good to get a different sort of.
Different perspective, yeah.
It's good.
Yeah. So Erica, you said this is a hill, so you would agree with making the change is what I'm.
Yeah, I remember we discussed it previously and I couldn't remember what it was that prevented us from making the change back then, but if it's as simple as declaring that that's how we want it to be when we make these edits, I think we should take that opportunity.
Do you know if there's any reason we couldn't make these changes?
Sounds like there is not.
Okay, and so if we made these changes upon signature of the updated bylaws going forward, that's how the titles would be. Does it impact any of the contracts like the ones we're signing right now with the old title?
I wouldn't think so.
Okay.
How do you feel about it, John?
I thought your logic was very good. And I like it when you go to some of these retreats, they invite the board chairs to these special functions. And also a president does connotate something that doesn't exist in our group. So, yeah, I'm not opposed to it. I think it's a smart move. I think just to be normal. I don't know if anyone else in the room has any perspective on it.
Sounds like a reasonable justification.
Yeah, I like that it doesn't recognize a power differential.
Yeah, just a responsibility differential during their term of being chair or vice chair or whatever. So
I like that way of putting it.
Yeah.
It's not a power differential, but a responsibility differential.
yeah, so I think it'd be wise to do it. Certainly, since we're right in this revamp, it's a perfect time to do it without putting in extra effort. So
Just a little find and replace in the document.
Yeah, so Mandy, would you, if we think this is a good idea, I mean, I'd trust you to just sort of go through and make all those red line changes.
I don't think we would need a motion at this time. We'd need a motion. We'd actually go to approve the changes. It's just we're getting a consensus
Yep.
that this is what we want to put into the document. So I think we'd like to have this ready for the next board meeting with all these changes. I'd ask for a week or so after this meeting to give anyone who wants to look at this document and submit anything other than this change we just verbally discussed. Like, again, I've got a whole bunch of little ones I want to show you, see if you agree.
The changes that you're making, John, they're just sort of,
Yeah, I can.
knocking off some rough edges, but nothing major, substantial.
Correct. It's just, I'll just show you like a quick example here. I bet I don't have mine with me. It's like one where we defined the board is the term we're going to use. And then later in the document, there's somewhere Board of Commissioners is used again. So it's like, once we define board is the Board of Commissioners,
Yeah.
everywhere else in the document should just say board. There's little things like that. I don't have it in front of me, but
Yeah, I trust,
Yeah.
I mean, I'll look at what changes you have to make. I trust you to make those changes. I have no
Yeah.
problem. I just like what we have here, with the exception of the name. So as long as you're not.
no substantive, just
big thing.
little syntax things or
Yeah.
whatever. And I'll go through them with you one at a time just to make sure they're clear, but
I do like having the order of business at the meetings in there with the revision to moving the CEO's report to the,
I added in with there no particular order, so then we can just adjust things as we.
but I like this.
like, for example, on page 11 of the redlined version, after the strikeout, it starts with the governing board. To me, I would strike the word governing because we've already defined the board as the board.
Yeah.
Right. So things like that is what I was looking at. And then the other one I had is the first one, which we already went over. Instead of newly or reelected, it's new or reelected board members.
Yes.
So that it reads, if you strike out that center
Or you want to be newly reelected. You want to be new or reelected.
Yeah, because if you take out or really, you'd have newly board.
Oh,
in the
I see what you're
term.
saying, yeah.
So you need to read without
Yeah.
that clause.
Yeah. that makes
Just,
sense.
again, things like that, I'm really.
No, I appreciate your attention to detail on all
Yeah.
this stuff, so I think it's good.
And then
It's
I'll send out a
impressive.
red line after I get everybody's, and I apologize for the format, but it was like converted to a Word from a
Yeah.
PDF, so you can't take out all the extra spaces.
Do you guys want an additional red line or only a red line if anything changes from the red line you have right now?
Well, I think I'd just like to see this with the red lines in it, plus any additional red lines. So like the change to president to chair and whatever John changes. So just, yeah, I'd like to see this again.
With additional red
Full
line.
red.
Yeah,
Yeah.
so we can just see all the things that are being changed.
Does anyone else here think they're gonna want to go through it and offer any changes, even if they're minute?
And the only change I noticed, I mean, there are those little things which I pay you looking at. I didn't look at a lot of those things. The only thing that really mattered to me was the type.
Yeah,
So,
you get the big one, you win on the big one.
I have no concerns about the small, just making it read more.
Harry, is there anything more you think you're gonna get if you read through it?
No,
Okay, so I'll just work with you
Okay.
in the next few days, business days. We'll just go through the document till we're both happy and then we can ship out a copy to everyone.
Sounds good.
And we'll ask for you to have read that and be ready to make a motion on it at the next meeting.
Okay,
Yeah, that sounds very good.
great.
Yeah.
Good plan.
thank you. I think it would be nice to have no order to the, I mean, we'll have an order for the agenda, but
It's
it'd
flexible.
be nice for mine, I think, to come last.
Yeah, do
because
you have
it's
any issue?
Like,
going
hey, I'm
forward?
gonna take Dr. Thomas's thunder and then Stacy's and everybody's. So I think it'll help with the flow and I think it'll support the admin team a little bit better versus me coming in and taking all their light.
Yeah, well, to me, it gives you a chance to reiterate the important bits we've already heard. But everyone gets a chance to shine on their own before.
So I like that. Thank you.
Okay.
And that was your suggestion, Don. I appreciate that.
and I know it says in no particular order, but we have no intention of changing the, I mean, other than the CEO's report. We have no intention of changing the order.
No,
We can like put presentations before public comment if we wanted to, if we have a bunch, it just gives
Right.
us that flexibility.
Yeah, I was just checking.
we just want to be out of, against our own bylaws. That's the only thing we're trying to fix. But
Yeah.
you are correct. We're not trying to actually change anything else. Just give us the flexibility to,
Yeah,
And then put call to order at the end of it.
yeah, there we go. So, very good. All right, anything else under new business? Okay, so we're gonna go into executive session. I've got things related to personnel that I want to talk about, and we also have then real estate we want to talk about.
Yeah, just 50 minutes for my stuff.
Okay, and I'll say 10 minutes for my stuff, so 25 minutes. But I also want to give you guys this draft to read in quietness before executive session starts. So why don't we take 12 minutes for executive session? We'll start at 8:05. And we'll have a 25-minute executive session. We'll cover personnel and real estate. So we will recess into executive session to evaluate the qualifications of an applicant for public employment and also real estate transactions. This will be under RCW 42.30.110 subsection 1 subsection G. That's satisfactory. Okay,
And I'd just like Dirk Thomas to stay for the first 3
Perfect.
minutes.
excellent. So Dr. Thomas, we stay. So let's recess until
Is
8:05.
there any action anticipated?
Yes, there potentially could be a vote when we come back in a public session. Thank you very much. Not doing good tonight. So we'll recess until 8:05, and we'll begin an executive session. I'd like the commissioners to each take one of these and try to read it in the quietness before we start talking at 8:05 and get your food and read whatever you want. So thank you, everyone. So we will take a short break and then reconvene at 8:05 into executive session.